Hi guys, give me a thumbs up if I'm visible to you and we are loud and clear. So I hope you have given this test and we will be discussing the question now. Apologies because there were some technical issues. The PPT was not showing up, so we had to take few minutes. Now all things are sorted and we'll start discussing the questions. And I hope because the questions were mostly from the hemat side and nephro side, from your path knowledge also you would have answered these questions. So let's get to the questions directly. So this was the first question that we faced. In this question, just give me a second. I'm not able to see any of your comments. Just give me 1 second, guys. Okay, so let's get going. So here in this question, we had a 32-year-old male who presented with facial edema and hypertension 2 weeks after an episode of sore throat. 2 weeks after an episode of sore throat. Urine analysis shows red cells. Serum complement levels are normal. What is the most likely diagnosis? So the key clue here is the complement levels. So what do you think? What type of... Okay, so as we look at the symptoms, we understand that the symptoms are suggestive of nephritic syndrome, right? Hematuria, facial edema, and hypertension. So it is suggestive of nephritic syndrome. So my diagnosis is nephritic syndrome. Now, nephritic syndrome has so many causes. So it is a key clincher here. Yes, there is history of sore throat. History of sore throat is encountered in two of the conditions given. One of them is post-streptococcal glomerulonephritis. The other one is IgA nephropathy. Post-streptococcal glomerulonephritis and IgA nephropathy. Okay, Usman Said, what makes you think that it is IgA nephropathy? Well, the key differentiating feature is the complement levels. So there are a lot of glomerulonephritic conditions where the complement levels get altered. So in IgA nephropathy, we are expecting, because see, post-streptococcal glomerulonephritis or PSGN is a condition where there is immune complex deposition. Means what are these immune complexes? The antigens, which is usually bacterial antigens, and antibodies produced by the body. They both fuse and form a complex, and those immune complexes get deposited in the glomeruli. And during this deposition, there is depletion of the complement levels. So PSGN is associated with low complement levels. On the other hand, IgA nephropathy is not associated with low complement levels. So here we will have normal complement levels. So keeping these points in mind, absolutely right. So keeping these points in mind, we are going ahead with the IgA nephropathy or Berger's disease as our answer. So IgA nephropathy or Berger's disease is going to be our answer, because in IgA nephropathy, we expect the complements to be normal. In case of PSGN, the complement will be depleted. Clear? Okay, so now what is happening in IgA nephropathy? In IgA nephropathy, IgA production increases following the sore throat, and this IgA, especially IgA1 subclass, gets deposited in the glomeruli. And this deposition is not an immune complex deposition, so there is no depletion of the complements. Here, the complement levels get depleted. Okay. Next question. A 40-year-old woman presents with fever, rash, arthralgia, and oliguria after starting a new medication. Urine analysis reveals eosinophils. Which of the following is the most common cause of her symptoms? Acute glomerulonephritis, interstitial nephritis, renal artery stenosis, thrombotic microangiopathy. What do you think is the diagnosis here? Fever, rash, arthralgia, and oliguria after starting a new medication. If it is usually glomerulonephritis, patient present with what we call as nephritic syndrome. Nephritic syndrome. And what are the key features of nephritic syndrome? There will be hypertension, hematuria, and facial puffiness or periorbital edema. Periorbital edema. So these are the classical features of nephritic syndrome. And in these patients, when we do urine microscopy, the urine microscopy is going to show what are the findings we're expecting in urine microscopy when there is glomerulonephritis, glomerular injury. Of course, you will have hematuria. Apart from that, yes, you will have dysmorphic RBCs. Presence of dysmorphic RBCs, the RBCs whose shape is changed, are highly suggestive of glomerular injury. Along with that, all these RBCs, which are now making their way into the renal tubules through injured glomeruli, will be impregnated onto the hyaline cast, giving rise to what we call as red cell cast. Red cell cast. So dysmorphic RBCs and red cell casts are highly suggestive of glomerular injury. We are not getting any of this. Neither this patient has got hypertension or hematuria or periorbital edema, nor anything is mentioned about dysmorphic RBCs or the red cell casts in the question. So that means this is not glomerulonephritis. Renal artery stenosis, as we know, is one of the causes for secondary hypertension. Here patients present with secondary hypertension. They present with secondary hypertension. It can be. Patients may present as refractory hypertension. Now, what do I mean by that? When renal artery is stenosed, the blood flow to the kidney is reduced because the renal artery is narrowed. And because of this reduced perfusion of the kidneys, there is increased activation or upregulation of RAS, the renin-angiotensin-aldosterone system. So that leads to increased production of aldosterone, increased production of angiotensin 2. Angiotensin 2 will cause vasoconstriction. Aldosterone will increase the sodium and water reabsorption and increase your BP. Until and unless the stenosed renal artery is sorted out, patient's BP will not or may not be responding to the conventional medications. That's why they may present as what we call as resistant hypertension. May present as resistant hypertension. Now, what is the definition of resistant hypertension? Hypertension that is not controlled to the target value despite use of 3 drugs, out of which at least one is a diuretic. All the three drugs are used at the optimally tolerated dose. Still not controlled, we'll call it as resistant hypertension. One of the common causes for resistant hypertension is renal artery stenosis. Right? Then thrombotic microangiopathies, they will present with features of hemolysis and thrombocytopenia. They will have thrombocytopenia. Why there is thrombocytopenia and thrombotic microangiopathy? In thrombotic microangiopathy, there will be formation of large number of tiny clots in the small blood vessels. Because the clots are formed in small blood vessels, we're calling it as microangiopathy. But when I'm making a clot, I'm consuming coagulation factors and I'm consuming platelets to form that clot. So because of that, my platelet count will be decreased. None of that is being talked about in the question. So what question is talking about? The key points that question is emphasizing is the presence of rash. I want your attention there. New medication being started recently, and urine analysis shows eosinophils. This is characteristic of drug allergy. So whatever was a new medication, patient has developed the drug allergy. That explains why he has developed fever, rash, arthralgia. Now this drug allergy can affect the kidneys as well. And in the kidneys, what do they affect? See, generally when we classify the disorders of the kidney, how do we classify? The disorders of the kidney are classified as glomerular disorders, tubular disorders, and interstitial disorders. So we know that this is the glomerulus that we are talking about. And then we have proximal convoluted tubule and loop of Henle, distal convoluted tubule, and collecting duct. So the diseases that affect the glomeruli are glomerular disorders. This is what we called as glomerulonephritis. The examples we just studied about IgA nephropathy, we studied about PSG, and these are all glomerular disorders, right? Disorders affecting this structure. I'm going to call them as glomerular disorders. Just give me a second. So now these disorders, we will call them as glomerular disorders. And these glomerular disorders, as we know, we further classify them as based on the presentation, whether they present as nephritic syndrome or nephrotic syndrome. So, can you give me the examples for the conditions that present as nephrotic syndrome? Now, what are the features of nephrotic syndrome? Nephrotic syndrome patients often have hypertension. They will have dyslipidemia, and they will have nephrotic range proteinuria. What is nephrotic range proteinuria? Losing more than 3.5 grams of protein per day. Okay. Now, the question is examples for the glomerular disorders that will present with nephrotic picture. So we know that in pediatrics it is minimal change disease, right? And then if you want me to give you an example from the adult side, I would say FSGS. Nephritic syndrome is where patients primarily present with hypertension, periorbital edema. Here in these cases of nephrotic syndrome, they have generalized anasarca, generalized edema. Here it is kind of restricted to periorbital edema, hypertension, periorbital edema, and hematuria. Hematuria. The examples for these disorders, the nephritic syndrome, PSGN, IgA nephropathy, these are classical examples where patient presents as nephrotic syndrome, as nephritic syndrome. Okay, just give me 1 second, guys. Again, I'm facing some technical issues. Okay, sorted. Now this nephrotic syndrome, we know how to identify them. We have to primarily identify nephrotic syndrome cases because of the nephrotic range proteinuria. We will have proteinuria in nephritic syndrome also, but not more than 3.5 grams per day. It will be less than that. These are classically identified by hypertension and hematuria. And these are the conditions where often in urine microscopy, we will have dysmorphic RBCs. Presence of dysmorphic RBCs is highly suggestive of injury to the glomerulus. Okay. Then the second set of disorders which are affecting the tubules. Tubules. We will call them as tubular disorders. A classical example that comes to my mind is acute tubular necrosis. Acute tubular necrosis. So those are tubular disorders which are affecting the tubules. So anything that affects these, we will call them as tubular disorders. Example for tubular disorders right now I'm quoting is acute tubular necrosis. Now, what is the usual presentation of acute tubular necrosis? When the tubules get damaged, remember tubules are concerned with reabsorption of solutes. So when tubules get damaged, the reabsorption of solutes may be affected. So we may end up presenting with either oliguria or polyuria. So patient may have oliguria or polyuria. Now you may be again wondering, sir, why both oliguria and polyuria are possible when tubules are damaged? Remember, tubule damage can happen because of multiple mechanisms. One of them is tubules getting clogged by precipitation of substances. For example, someone is receiving acyclovir injections, and acyclovir can now precipitate in the renal tubules. It can cause the tubule blockade. Now the drainage of filtrate in the form of urine is affected because the tubules are getting all clogged by this precipitation of acyclovir. Then I will have kidney failure. Of course, I will have polyuria. Why polyuria? Let us say that these tubules are dysfunctional or damaged but not blocked. So then the job of tubules is to reabsorb, like primary convoluted tubule. I'm reabsorbing most part of water, like almost 90% of the water gets reabsorbed in the loop of Henle and the proximal convoluted tubule. Only 10% is reabsorbed in the distal convoluted tubule. So when these tubules are dysfunctional, I will not be able to reabsorb water. So I will lose a lot of water in urine. I can end up with polyuria. Then we reabsorb sodium, glucose, all these in the tubules. I may not be able to reabsorb them. Again, they will be excreted in urine. Especially glucose is highly osmotically active. So when glucose goes in the urine, I will also be losing water. So there are multiple mechanisms for oliguria or polyuria. A hallmark of this acute tubular necrosis is fractional excretion of sodium more than 2%. I'm just giving you the examples how we classify the disorders of the kidney. Now, in the kidney, apart from the glomeruli and tubules, or apart from nephron, is there anything else present? Well, to hold all these nephrons together, we have connective tissue. So those disorders which affect this connective tissue, will call them as interstitial nephritis, acute or chronic. And the most common cause for interstitial nephritis is drug allergy. So there is another group of disorders which are affecting the surrounding connective tissue. So let us say that around these nephrons there is all connective tissue present, and those connective tissues, disorders affecting these connective tissues, disorders affecting these connective tissues, just give me a second, we will call them as interstitial nephritis. So renal disorders can be classified as tubular disorders, where tubules are affected, and glomerular disorders, where glomeruli are affected, and the connective tissue disorders, which is primarily the connective tissue that is surrounding the nephrons, are affected. Examples: acute involvement, we will call it as interstitial nephritis or acute interstitial nephritis. Acute interstitial nephritis. And when there is chronic involvement of this, often the tubules also will be involved. So we'll call it as chronic tubulointerstitial kidney diseases. Chronic tubulointerstitial kidney disorders. Or CTIDs. Acute is acute interstitial nephritis. Chronic is chronic tubulointerstitial kidney disorders. An example that I can quote for the chronic tubulointerstitial kidney disorders is Balkan nephropathy. That's a classical example. Then analgesic nephropathy is also chronic tubulointerstitial kidney disease. For acute interstitial nephritis, the most common cause for acute interstitial nephritis is drug allergies. So if you're allergic to some drug, body will have an allergic reaction. There will be rise in eosinophils. Those eosinophils are going to cause the tissue inflammation, and even the connective tissue of the kidney can become inflamed. And a potential clue that this patient is having interstitial nephritis because of drug allergy is presence of eosinophils in the urine, or eosinophil urea. Eosinophil urea. Now that this question is talking indeed about the presence of eosinophil urea, eosinophils in the urine, and also background history of new drug being exposed, patient also having developed a rash, everything fits into the classical description of our interstitial nephritis. So we'll stick to interstitial nephritis as our diagnosis. Clear? Okay, next. A 60-year-old man with chronic kidney disease stage 4 has an ECG showing tall peak T waves and wide QRS complex. Which of the following should be administered first? So what is the complication that we are suspecting here? The presence of the tall peaked T waves and wide QRS complexes. What does that indicate? So what happens in a patient with CKD with respect to electrolytes? Remember, our kidneys are chronically damaged. So glomerular filtration has come down, especially we're talking about the stage 4 here. So GFR is very low, and thus I may not be able to excrete potassium. So it will lead to increase in serum potassium values. So we will have serum potassium go up, what we call as hyperkalemia. Hyperkalemia leads to certain ECG changes. ECG changes. What are the ECG changes? So when we look at the ECG, if this is how my ECG is going to look like. as the potassium level starts going up, there are few changes. One change that we can expect is the T wave becomes tall and peaked. Tall, peaked T wave. You can also have tall T wave in MI, acute MI, but there it will not be peaked. Here it is peaked. Peaked is the term that we are using. In case of acute MI, this will be blunt. It will not be sharp or peaked. So I'm getting that is one change. Second, progressively there is flattening of the P wave. P wave starts becoming flatter and it may eventually disappear. And the QRS starts becoming wider. So QRS widens, P starts becoming flat and T starts becoming tall. Eventually what happens? The ECG looks like P has disappeared, QRS has become very wide and T has become tall. So eventually that's the ECG picture we're going to get, and we will call that as sine wave pattern. And the presence of sine wave indicates that you will end up with fatal ventricular arrhythmias, and it is at very high risk of death. The patient is at very high risk of death. Now if I have to treat this patient, main thing is I have to reduce the risk of death first. Now why are they going to develop? Because this hyperkalemia is altering the conduction of the electrical impulses in the heart, pushing you towards fatal arrhythmias. So step number one is to prevent heart from being affected by this high potassium, and then step number two, lower the potassium value. So among these, which agent can reduce the impact of hyperkalemia on the heart? Yes, the calcium gluconate. Furosemide can make you excrete more calcium. Sodium bicarbonate, if there is an underlying acidosis, it is going to help there. Insulin and glucose. Insulin helps shift potassium from extracellular to intracellular compartment. All of them are useful. But what examiner is asking is which of the following should be administered first. So what is the first step? To protect your heart from being affected by high potassium values. And to protect that, I have to use calcium gluconate. Calcium gluconate does not, please remember, it protects heart from impact of hyperkalemia. Impact of hyperkalemia. Calcium gluconate does not decrease serum potassium values, because it has nothing to do with the potassium excretion or shift of potassium from intra to extra or extra to intra. But it is highly effective in reducing the deleterious effect of potassium on the heart. So step number one is that. Now after this, we can go ahead with giving diuretics to make you excrete more potassium. I can give you insulin with dextrose to shift potassium from extra to intra. So these will come as next step. So immediate first step is going to be calcium gluconate. Okay, next question. A 28-year-old woman presents with bilateral flank pain, hematuria, and a family history of kidney disease. Ultrasound shows multiple renal cysts. Which of the following is most likely inheritance? So what do you think it is? What is the topic that examiner is talking about? Okay, I think Usman, right? I forgot to address the most commonly associated drugs causing interstitial nephritis. Drug allergy, among them, the most commonly associated drugs which are known to cause are antibiotics. And within antibiotics, I want you to remember it is the beta-lactam antibiotics, the common used amoxicillin, ampicillin, penicillin, right? These are including the cephalosporins. Beta lactams are the most common antibiotics associated with drug-induced interstitial nephritis. Yes. So here, why can't it be autosomal recessive polycystic kidney disorder? Why can't it be autosomal recessive polycystic kidney disorder? Why should I think of only autosomal dominant? Yes, you are right. It is autosomal dominant because autosomal dominant is where patient present into adult life. Autosomal recessive polycystic kidney disorder, which is due to PKHD mutation, patients present in intrauterine or in the first year of life itself with intrauterine as oligohydramnios, or in the first year of life itself as the absolute renal failure. Yes, good. So because this patient has lived into the adulthood, it can't be autosomal recessive. So these patients present in usually intrauterine life. It could be fetal death, presentation in intrauterine life as oligohydramnios. Because they have renal dysfunction, the child is not excreting urine out, so they will have oligohydramnios, and it may lead to intrauterine death. So it is going to be, so diagnosis here we will stick to autosomal dominant polycystic kidney disease due to PKD1 or PKD2 mutations, where mostly patients start developing cysts in the kidneys. By the time they are into fifth or sixth decade, they will end up with renal failure or CKD. Before that, one of the common presentation is bilateral or unilateral flank pain, hematuria, especially when a cyst ruptures or there is bleeding into the cyst. So the story fits into the description of autosomal dominant polycystic kidney disorder and not autosomal recessive. Okay, good. Next. Which of the following finding is most specific for diabetic nephropathy in a patient with type 1 diabetes mellitus? Which of the following is most specific for diabetic nephropathy in a patient with type 1 diabetes mellitus? What do you think should be the answer here? Can I have microalbuminuria in other conditions other than diabetic nephropathy? They're asking most specific. All of these conditions, all of these findings may be associated with diabetic nephropathy. Can I have microalbuminuria in hypertensive nephropathy? Yes, it's not specific for the diabetic nephropathy. Elevated serum creatine, AKI, CKD, any conditions we can have. Hyaline cast. So elevated serum creatinine can be expected in AKI as well as CKD irrespective of the cause. Microalbuminuria is seen in diabetic nephropathy, but not just diabetic nephropathy, but even in patients with hypertensive nephropathy. Hyaline casts are typically seen in patients in normal individuals, and increased number of hyaline casts in prerenal AKI. Prerenal AKI. Retinopathy. Well, remember, you may say, sir, hypertension also has retinopathy, but we know that hypertensive retinopathy can be easily diagnosed as a separate entity from the diabetic nephropathy. So if there is an individual who is type 1 diabetic and he also has diabetic retinopathy, and in that case, whatever renal function alterations I'm getting, I can blame it on the diabetic nephropathy. So that makes the presence of retinopathy highly specific for the diagnosis of the diabetic nephropathy in a patient with diabetes. Good, true. So that because the microalbuminuria is the most sensitive and the early marker of the renal injury and hypertension as well as diabetes, we continue to monitor all these diabetics and hypertensives for microalbuminuria for appropriate intervention. Good. Okay, next, a 40-year-old woman presents with fatigue, pallor, oliguria after an episode of bloody diarrhea. Lab results show anemia, thrombocytopenia, and elevated creatine. Peripheral smear shows cystocytes. Which of the following is most likely diagnosis? So from the picture, we understand that there is thrombotic microangiopathy. Thrombotic microangiopathy following an episode of bloody diarrhea. So the clue here is development of bloody diarrhea. So why can't it be TTP? Why should I think of only hemolytic uremic syndrome? Yeah, I agree. The answer is hemolytic uremic syndrome because there is exposure to, probably an exposure to a specific variant or strain of E. coli. But why not TTP? Yeah, TTP does not have any correlation with bloody diarrhea or the dysentery. TTP is, yes, the diarrhea is not present in the TTP. So because of the presence of diarrhea, see, otherwise the overall diagnosis here, because there is thrombocytopenia, abnormal renal function and anemia, our overall diagnosis is what we call as thrombotic microangiopathy. Thrombotic microangiopathy means here there is injury to the small blood vessels that has resulted in formation of multiple small clots, and the clots have used up the coagulation factors and the platelets. That's why platelet count is low, and because the blood vessels are small, blood vessels are blocked, the perfusion of the kidneys is affected, so we will have elevation in the creatine. And now that blood passes through, see, the basic thing we have to imagine for the thrombotic microangiopathy is this is a blood vessel. In this, for some reason, there was an endothelial injury or something, and I have formed clots. So all the platelets are used up in these clots. Because of that, I have thrombocytopenia. Okay. And now what is this? This is the clots. That's why we're using the term thrombotic. Where is it occurring? In small blood vessels, microangiopathy. Now platelets are used up. That's why platelet count is low. The perfusion of the organs, including tissues, will be affected because of the clot burden. So organs will fail. I can have elevation in creatine. Now, as the blood passes through these blocked blood vessels, RBCs often get damaged and lysis, right? There is hemolysis, intravascular happening inside the blood vessel. So we'll end up with hemolysis. That explains why I'm having anemia, right? Collectively, we'll call it as thrombotic microangiopathy. So what are the features of these thrombotic microangiopathy? The features include the first one, there is formation of thrombosis in small vessels, and because of this thrombosis there is decrease in the platelet count or thrombocytopenia. Okay, now that there is a formed clot, there is also use of, because platelet are not the only thing that is being used in forming a clot, even the fibrin is being used, right? So we'll say this consumptive coagulopathy means all the coagulation factors are being used up in forming these clots. So now I have deficiency of coagulation factors. So if there is any trauma, I will start bleeding because whatever coagulation factors I have, they're all being used up in forming these tiny clots in small blood vessels. We'll call it as consumptive coagulopathy because production of coagulation factors is not affected. Whatever is being produced is all being consumed by these clots. That's why I don't have sufficient coagulation factors. So we'll call it as consumptive coagulopathy. The next thing that's going to happen here is all the blood that is passing through it, RBCs, will go through breakdown or lysis, right? I will call it as intravascular because inside the blood vessel there is development of hemolysis. And because of this intravascular hemolysis, I may end up with anemia. Anemia is happening because of intravascular hemolysis. Now this can happen because of various causes. One of them is ADAMTS13 mutation or the specific strains of E. coli like E. coli 0157. So in case of HUS, it is because of the E. coli infection which is triggering this inflammatory cascade. In case of TTP, ADAMTS13 abnormalities. In case of disseminated intravascular coagulation, it is typically a complication. Typically, a complication of sepsis can also happen as a complication of trauma, drugs, and all, but most commonly a complication of sepsis. So when there is sepsis, there is production. Like you have bacteria. Bacteria have like there is large load of bacterial load in the circulation, and in response to that, body produces inflammatory cytokines. Those inflammatory cytokines may cause endothelial injury, and once there is endothelial injury, Virchow had said triad of Virchow's, endothelial injury, hypercoagulability, and stasis increase the risk of developing clots. So now that there is endothelial injury caused by sepsis, there is formation of platelet plug, then fibrin mesh, and I'm creating a clot. So how did I ended up with clots? Endothelial injury happened as a result of inflammatory cytokine production, which was in response to infection. Now that I have injured the endothelium, multiple areas clots will be formed. Those clots will use up the platelets, coagulation factors, and now there can be hemolysis. This condition we call it as disseminated intravascular coagulation. So in this question, there is nothing pointing towards DIC. There is no history of polytrauma. There is no history of sepsis, right? Only thing that I'm getting in addition to the features of thrombotic microangiopathy is that there is presence of bloody diarrhea. So keeping those points in mind, we will go ahead with us as our diagnosis. Hemolytic uremic syndrome as our for the development of CKD. Majority of them would have had hypertension before they develop CKD. So it's not going to be the most common cause. Renovascular hypertension is the most common cause. Okay, next. A 10-year-old boy presents with periorbital swelling and dark colored urine. On examination, BP is 140/90. Urine analysis shows RPC, cast and mild proteinuria, and ASO titer is elevated. So what is the diagnosis? So I want you to remember that after sore throat, if that is followed by acute glomerulonephritis, we have two differential diagnoses. The first differential diagnosis is PSGN. Second differential diagnosis is IgA nephropathy. How do we differentiate? IgA nephropathy, the patients usually present within 3 days of sore throat. PSGN generally take more than 3 days for the presentation. That's why IgA nephropathy is also called as synpharyngitic nephritis. Means as the pharyngitis is going on, same time you present with nephritis. PSGN is called as post-streptococcal glomerulonephritis. You have a streptococcal infection later, usually 1 week or so later, patient present with glomerulonephritis symptoms. Okay. Apart from that, if you ask me what is the best way to differentiate, it is still the complement levels. In PSGN, the serum complement levels, because PSGN is an immune complex deposition disease, complement level will be decreased. But in IgA nephropathy, there's only IgA deposition. There is no deposition of the immune complexes, so the complement is not being utilized. So complement levels will be normal. So this is one point that you should remember, apart from the duration of presentation after the sore throat. So in this case, they have given a clue towards PSGN because ASO titer is elevated. So if I take into account the elevated ASO titer, the diagnosis for this question is going to be post-streptococcal glomerulonephritis. Now what should be the answer here? Most likely, which of the following finding is most likely seen in? So we just learned that complement will be depleted in PSGN. So keeping that in mind, we can go ahead with option A as the answer. We are expecting low serum complement levels. If I had not mentioned ASO titer, instead the question mentions that the complement is normal, or the question mentioned that on day 2 or day 3 itself patient presented with the nephritic picture. In that case, the diagnosis becomes IgA nephropathy. And if I'm thinking of IgA nephropathy, there you can say yes, elevated serum IgA levels. Said Usman, absolutely right. So the most common cause in adult secondary hypertension? No, Said Usman. The most common cause for the secondary hypertension in adults is still the renovascular hypertension. Why not CKD? Because remember, what is the most common cause for CKD? Diabetes mellitus or diabetic nephropathy. And the second most common cause for CKD is hypertensive nephropathy. Now, the hypertensive nephropathy accounts for close to 1/3 of the cases, and close to 2/3 of the cases are diabetic nephropathy. Among the patients who are diabetic and they end up with nephropathy, majority of them, even before the onset of microalbuminuria, they are also hypertensive. So close to 50% of patients of CKD, they're hypertensive before they develop CKD. The remaining patients will eventually end up developing hypertension because of CKD, but majority already had the hypertension. So now in these cases, we can't call these hypertensive patients as secondary hypertension. They are essential hypertension who have eventually developed CKD, right? So that's why we should stick to renovascular hypertension as the most common cause for secondary hypertension in adults. Okay, now let us address this next question. A 60-year-old woman with a history of Sjogren syndrome presents with fatigue and muscle weakness. Lab findings include metabolic acidosis, hypokalemia, and normal anion gap. Which of the following is most likely diagnosis? What do you think should be the answer here? History of Sjogren presents with fatigue and muscle weakness. Lab findings include metabolic acidosis with normal anion gap. Normal anion gap. So with this information, what is the first condition that we can rule out? There is acidosis with normal anion gap. Kushbu, I didn't get your doubt. Can you let me know the doubt again? Among the options, what can I rule out the moment I say normal anion gap? You know that we classify the metabolic acidosis into two broad groups based on anion gap. So if the anion gap is more than 12, such conditions we call it as high anion gap metabolic acidosis. And if the anion gap is less than or equal to 12, such conditions we will call it as non-anion gap or normal anion gap metabolic acidosis. What are the examples for the high anion gap metabolic acidosis? You can remember it with the mnemonic. What is the mnemonic? Mud piles. And when you look at the mnemonic and you look at the individual causes, you will notice that most of them are toxins. Methanol poisoning, salicylic acid poisoning, diabetic ketoacidosis. In all these cases, an unmeasured anion acid is being added to the body. In diabetic ketoacidosis, that comes from keto acids. Keto acids are being added to the body. In salicylate poisoning, salicylic acid is being added to the body. These extra acids being added to the body accounts for that anion gap that we are getting. In case of the non-anion gap metabolic acidosis, nothing extra is being added. The classical examples for the non-anion gap metabolic acidosis is renal tubular acidosis. And the classical examples I want you to remember for the exams for the high anion gap metabolic acidosis from the mud piles ka U, that is uremia, and mud piles ka D, which is diabetic ketoacidosis. Diabetic ketoacidosis. Mud piles ka L, that is lactic acidosis. Here lactic acid is an extra acid being added to the body. Now, what is uremia? High urea levels that can happen in patients with acute kidney injury as well as CKD. Why would I develop acidosis? Good. Why would I develop acidosis if I have CKD or AKI? Kidneys are not able to work. So why will I develop acidosis? Because when we talk about the kidneys, so they do two functions. One is H plus secretion. We secrete H plus ion, and bicarbonate. H plus is our acid and bicarbonate is our base. Bicarbonate kidneys can reabsorb. So bicarbonate reabsorption and H plus secretion is the function of kidneys. So if any one of them is impaired, if I'm not able to secrete H plus, I will have high amount of H plus in the body. So I will be having acidosis. Or if I'm not able to reabsorb base, I will have acidosis. In renal tubular acidosis, that is exactly what is happening. Either we have impairment in H plus secretion or impairment in bicarbonate absorption. Bicarbonate absorption primarily occurs in PCT. So if there is a defect of bicarbonate reabsorption, we will call it as proximal RTA or type 2 RTA. And H plus secretion happens in DCT and collecting duct. So if that is not happening, we will call it as type 1 or distal RTA. In type 4, there is resistance to aldosterone action or there is decreased aldosterone production. Okay. Now in CKD also, don't you think exactly same thing is happening? Why am I having metabolic acidosis? Because I'm not able to excrete H plus and reabsorb bicarbonate. So why should I have RTA as non-anion gap and AK and CKD as high anion gap? What is being added in the body in these cases that it creates a high anion gap metabolic acidosis? So if there is no other abnormality than H plus secretion or bicarbonate reabsorption, I should end up with non-anion gap metabolic acidosis. Can anybody tell me? Uremia, Khushbu Kumari, absolutely right. Uremia, lactic acidosis, classical examples for high anion gap. But uremia, what is extra being added in the body that is creating this anion gap? Lactic acidosis, lactic acid is being added. Ketoacidosis, ketones, keto acids are being added. Salicylic acid poisoning, salicylic acid being added. Yes, kidneys are not only involved in secretion of H plus and bicarbonate, they are also involved in excretion of phosphate and sulfate. This excretion is also function of kidney. So when kidneys become dysfunctional, there is rise in phosphate levels and sulfate levels, and these are also acid anions, so that this addition creates the anion gap. So retention of sulfates and phosphates is a reason why we are getting anion gap. Okay. Now coming to the renal tubular acidosis. So if there is impairment in H plus secretion, then that is distal or, see, remember, if this is the nephron that we are looking at, if this is a nephron that we are looking at, so please remember that bicarbonate absorption happens in the proximal convoluted tubule and the H plus secretion happens in DCT and to some extent in collecting ducts. So if I'm not able to reabsorb bicarbonate, we will call it as proximal or type 2 renal tubular acidosis. If I'm not able to secrete H plus, we will call it as distal or type 1. Okay. And if I have aldosterone deficiency or resistance to its action, we will end up with type 4, which again aldosterone acts through iliac channels distally, so it will be counted as distal. Okay. Now, how do I differentiate between these two? The main differentiating feature is going to be urine pH. In any given question, it's going to be urine pH. Why? Because as the filtrate is done and the filtrate travels to the different parts of the nephron to become the urine, I add H plus. As I add H plus into the urine, urine becomes acidified. When urine becomes acidified, my urine pH decreases at acidic pH. If I'm not able to secrete H plus, I cannot acidify urine, so urine remains less acidic. So in case of, let us say, proximal renal tubular acidosis, bicarbonate absorption is impaired, but there is nothing stopping H plus secretion. So I will secrete more H plus and make the urine acidic. So the pH will be less than 5.5. But if it is distal where H plus secretion itself is impaired, then I may not be able to add H plus into the urine and may not acidify it. So the pH will remain more than 5.5. More than 5.5. Okay. Second feature that can help you to differentiate is presence of Fanconi's syndrome. So can anybody tell me what is this Fanconi's syndrome? So please remember, this proximal convoluted tubule is not only concerned with bicarbonate absorption. I am absorbing glucose, most part of it in the proximal convoluted tubule, most part of sodium in the proximal convoluted tubule, most part of water in the proximal convoluted tubule, and majority of the filtered amino acids. Proteins we don't filter, but amino acids, they are all being reabsorbed in PCT. But for some reason, this PCT is damaged. I'm not only going to lose bicarbonate in the urine, I will also lose glucose. I will also lose amino acids in the urine, right? So this condition where there is profound loss of solutes because of the proximal convoluted tubule damage is what we call as Fanconi syndrome. Now, where are we going to expect it? Of course, where proximal convoluted tubule is damaged. So Fanconi syndrome is present in patients with proximal or type 2 RTA, not in case of distal forms, that is type 4 or type 1. Okay, clear? Now, if I'm not able to absorb solutes in the proximal convoluted tubule, one of the solute also includes calcium, right? So high amount of calcium flows through the tubules, precipitate in the tubules and cause nephrocalcinosis and renal stones, which is not usually encountered in other conditions. So if there's a question which is talking about the nephrocalcinosis, again it is pointing towards, yeah, Syed Usman, absolutely right. So you're losing everything in urine in case of Fanconi's syndrome. If there's a question which is talking about nephrocalcinosis, we are thinking about the distal renal tubular acidosis. Okay. Now in this question, what all information we had? The moment I know that anion gap is normal, I have ruled out diabetic ketoacidosis. We're left with the type 1 renal tubular acidosis, type 2 and type 4. Type 4 we will only think when the question is talking about aldosterone deficiency or resistance. Deficiency or resistance. Deficiency happens when in hypoaldosteronism, resistance happens when there is a damage to the renal tubules or kidney. Okay. So now I have to differentiate between type 1 and type 2. Okay. So what feature is going to help me here to differentiate? Is there any feature that strongly helps us to differentiate it here between type 1 and type 2? This question is not talking about the urine pH. It's not talking about the Fanconi syndrome. It's not talking about the nephrocalcinosis. So how will I differentiate between these two conditions? How will I differentiate between the two conditions? Yes, the Sjogren syndrome is known to be a cause for the type 1 renal tubular acidosis. Type 1 renal tubular acidosis, because both type 1 and type 2 will have low potassium. Type 4, yes, we will have hyperkalemia. Why? Because we have aldosterone deficiency, and remember, aldosterone is responsible for sodium reabsorption. So in the renal tubules, when I reabsorb sodium, then only I will be able to secrete H plus out, means secrete potassium out. So if I reabsorb sodium, it creates an ion deficit. To compensate, I can excrete a potassium out. So I need this sodium reabsorption for potassium secretion. So if I don't have sodium reabsorption, no potassium secretion, and we can end up with hyperkalemia. So hypokalemia is again encountered in both the cases. So the only thing that makes me to go ahead with option A as the answer is Sjogren syndrome is a known cause for type 1 renal tubular acidosis. The proximal or the type 2 renal tubular acidosis is classically associated with the Fanconi syndrome and other related disorders. Okay, good. Next question. Which of the following best differentiates prerenal azotemia? Standard MCQ repeatedly asked. Which of the following best differentiates prerenal azotemia from ATN? Now, what is the difference between prerenal azotemia and ATN? So please remember, this is a glomerulus that we are looking at, and blood comes into it through an afferent arteriole and then leaves through an efferent arteriole, and from the Bowman's, it's a known cause. It's a known cause. Okay, so this is PCT. This is distal convoluted tubule, and collecting ducts. Now, what happens in prerenal azotemia? Let us say this is afferent arterial and this is efferent arterial. Blood comes into the glomeruli, and the pressure of this blood is the main driving force for the glomerular filtration. We create a filtrate. Now, in the prerenal azotemia, there is decreased perfusion pressure, and because of that, the glomerular filtration will decrease. Of course, kidney has its own autoregulatory mechanism. For example, if the filtration pressure in the glomeruli is decreasing, I can cause efferent arteriolar vasoconstriction and afferent dilatation, so that more blood can come in and exit is made difficult, so pressure inside the glomeruli will increase and I can still filtrate. This is basic autoregulation, right? Afferent vasodilatation is caused by prostaglandins. Efferent vasoconstriction is caused by angiotensin 2. This is how kidneys can continue to perfuse even when the continues to filtrate even when the perfusion pressure is decreasing. But if it is beyond the autoregulatory threshold, when BP is less than 80-60, kidneys may not be able to maintain autoregulation. Glomerular filtration will decrease. But what is the main reason? Decreased blood flow to the kidneys. Now, and in that circumstance, what do you want the kidneys to do with respect to sodium and water? The blood pressure is decreasing, blood flow to the kidney is reduced. What do you want the kidneys to do? Yes, so in case of prerenal azotemia or prerenal AKI, the most common cause being hypotension or decreased renal perfusion. So when there is decreased renal perfusion, the kidneys think that there is hypovolemia. So there will be activation of RAS, and as I activate RAS, renin angiotensin aldosterone axis, we will have angiotensin 2, which will cause vasoconstriction, including afferent arteriolar vasoconstriction, which facilitates glomerular perfusion, right? So there will be efferent arteriolar vasoconstriction, which increases the perfusion. Second, aldosterone will come and it will increase sodium and water reabsorption. So now at the iliac channels, there will be increased sodium reabsorption from the tubules. I'm reabsorbing most of the sodium, I'm reabsorbing most of the water. So now tell me the amount of sodium in the excreted urine. It will be high or low when I have prerenal AKI? Most of the sodium is being reabsorbed out from the tubule. So the amount of sodium I lose in the urine will be low. So the excretion of sodium is decreased when we have prerenal AKI. Second, water is also reabsorbed. So the urine that is going out will be highly concentrated. So this urine specific gravity and osmolality will be high. Sodium will be low, urine specific gravity and osmolality will be high. But what will happen if these tubules are damaged? That's what we call as acute tubular necrosis. In ATN, these tubules are damaged. So will I be able to reabsorb the sodium? These tubules are dysfunctional, so I may not be able to reabsorb the sodium. So the amount of sodium I lose in the urine will be high. The amount of water I lose in the urine will be high. So the acute tubular necrosis often presents with polyuria and high amount of sodium in the urine. So the fractional excretion means percentage of filtrate excreted as sodium in the urine will be high. So the most important investigation that helps us to differentiate between, so in case of prerenal AKI, we are expecting to have highly concentrated urine. With low sodium in urine. But in case of acute tubular necrosis, where tubules themselves are damaged, we will have relatively dilute urine because we are not able to reabsorb water, but we are also not able to reabsorb sodium, so we'll have high amount of sodium in urine. So in that case, can I say that if I look at urine specific gravity in patients with prerenal AKI, it will be high. Urine osmolality, because solutes are more, water is less, urine osmolality will be high. But in case of acute tubular necrosis, urine specific gravity will be relatively low because it is dilute, and urine osmolality will also be relatively low because it is dilute. But among all the investigations that we know, the single most important investigation that helps us to differentiate between prerenal AKI and acute tubular necrosis is going to be FeNA. FeNA stands for fractional excretion of sodium. So sodium excretion is increase in ATN. So more than 2% of the total filtered sodium will be lost in urine in ATN, and less than 1% will be lost in case of prerenal AKI. So if the FeNA is less than 1%, it is suggestive of prerenal AKI, and if FeNA is more than 2%, it is suggestive of ATN. Other investigations are useful, like serum osmolarity, as we just learned. It will be high in prerenal AKI, low in case of ATN, but they are not highly diagnostic or the most useful. It's not most useful. Most useful is going to be fractional excretion of sodium or FeNA. The best investigation to differentiate between prerenal azotemia and ATN is FeNA. Yes, good. Another thing, as you mentioned, in case of the prerenal AKI, there is no damage to tubules, there is no damage to glomeruli, so you will not have any abnormal casts. Damage to glomeruli produces RBC casts, and along with that it will have dysmorphic RBCs. That we are not going to get in this case because it is prerenal, there is no glomerular injury yet. Now tubular injury, when tubules are injured, we will have the epithelial cells of the tubules get shed into the tubule itself, and they get impregnated on the tromophosphol protein sheets called hyaline sheets, giving rise to what we call as renal tubular epithelial cell casts. Within this cell goes through degenerative changes and produce lipofuscin, and then it becomes muddy brown casts. So in case of the ATN, we get this renal tubular epithelial cell cast or muddy brown cast. In case of prerenal AKI, the normal hyaline cast that we get in normal individuals also, you may find them in higher numbers, but no other abnormal cast. Yes, that especially finding muddy brown and the RTEC cast is highly suggestive of the ATN. But if they ask, even with cast information, if they ask which one is the gold standard to differentiate, it is going to be FeNA. Regardless of what other information is given, FeNA will always remain the gold standard investigation to differentiate between prerenal AKI and ATN. Okay, next question. A 45-year-old male presents with epigastric pain that improves with meals. Endoscopy reveals gastric ulcer. Which of the following is the most appropriate next step in the management? Should I start triple therapy for H. pylori, PPI alone, or H. pylori testing before starting therapy or surgical referral? Yes, the fact of the matter, most common cause for the peptic ulcer. Most common cause for peptic ulcer is indeed, yes, H. pylori infection. But that does not mean that all of the peptic ulcers are caused by H. pylori. The second most common cause for the peptic ulcer is NSAIDs. And the third most common cause for peptic ulcer is corticosteroids. Then other drugs come into picture. But then randomly starting treatment for H. pylori without a documented evidence that H. pylori is responsible is uncalled for. So if you have a peptic ulcer, we know that majority of them will be caused by H. pylori, but we still need to do a diagnostic testing. Once the diagnostic testing confirms that you have H. pylori infection, then eradication treatment is started. And once I complete the eradication treatment, again I have to do testing to confirm that H. pylori is eradicated, because currently the treatment failure rate is quite high, especially the LAC regimen that is used for H. pylori has high failure rate because macrolide resistance in India is at all-time peak. So what is going to be the protocol or approach? You have a peptic ulcer diagnosis and endoscopy, do the diagnostic testing for H. pylori. Then if it is positive, then start him on the H. pylori eradication treatment, 10 to 14 days of treatment. After that, we have to give a gap of a month or more before we do a retesting to confirm the eradication. Once the retesting confirms that eradication, then you can say that H. pylori is eradicated. Yes. Multiple modes of investigation are possible. One is the urease breath assay. The other one is the urease test on the biopsy sample, right? And apart from that, the direct microscopy and biopsy. So among them, urease breath test and the urease test on the biopsy sample are considered as good investigations for initial diagnosis. For subsequent diagnosis, the urease breath, for eradication of treatment, the urease breath assay is more than enough. You don't have to think of the repeat biopsy and then doing the urease assay on the biopsy sample. But for initial diagnosis, the urease assay on the biopsy sample is considered as the best investigation over urease breath test for initial diagnosis. For confirmation of eradication, we don't want to go for one more invasive investigation, so you can stick to the breath urease test. So here I have to confirm the presence of H. pylori and then start the therapy. That will be my next step. Okay. A 60-year-old male with a history of long history of alcohol abuse presents with jaundice, ascites, and hepatic encephalopathy. His INR is elevated. Which of the following best indicates severe liver dysfunction in this patient? Alcohol, jaundice, ascites, hepatic encephalopathy. His INR is elevated. Presence of ascites indicates that he has severe liver dysfunction, or presence of jaundice or elevated INR or hepatic encephalopathy. So again, this question is kind of biased for two reasons. Presence of hepatic encephalopathy is a defining feature of liver failure. Means if you have hepatic encephalopathy, we will always count it as a very severe liver dysfunction. But even elevated INR is a marker used in various scoring systems for the recognition of severe liver dysfunction, right? More is the INR because all these coagulation factors are produced by liver. More the dysfunction of the liver, less is the coagulation factor production. More will be the PT, more will be the INR. So I'm really not sure the way the question is constructed, which answer should be taken as right. Because if there is encephalopathy, I would definitely take it as severe liver dysfunction. And if there is elevated INR, again I will take it as severe liver dysfunction. Because elevated INR is part of various scoring systems like the Madrid's discriminant function score or Child-Pugh score. Maybe the examiners would have taken this as the right answer. If you ask me personally, presence of hepatic encephalopathy also indicates severe liver dysfunction. In fact, we come across this term called acute liver failure. Acute liver failure. Earlier, the same condition was called as fulminant liver failure. Now, today we don't use the term fulminant liver failure. Now, how do we define it? It is defined as development of, let us say, patient has onset of jaundice today, and if within a span of 6 months, if he develops hepatic encephalopathy, we will count it as acute liver failure. So presence of hepatic encephalopathy had always been a marker of severe liver dysfunction. Okay, so even in the test, I don't know which was the answer chosen by the examiners. I would believe that they would have chosen elevated INR because it's part of various scoring systems. Okay. Next, a 50-year-old male presents with hematemesis. On endoscopy, esophageal varices are seen. Which of the following is the first line treatment to control acute bleeding? Octreotide, endoscopic sclerotherapy, endoscopic variceal ligation, propranolol. Which is the first line treatment to control acute bleeding. So basically we're having esophageal varices as a complication of portal hypertension. And now the patient is bleeding from the varices. So what is the first line treatment? Okay, now what would you choose if there is another option E? E is terlipressin. Terlipressin. What would you choose? Would you choose octreotide, terlipressin, endoscopic sclerotherapy, endoscopic variceal ligation, or propranolol? Yes, good. So for the first line treatment, we basically wants to induce the vasoconstriction so that the blood loss comes down, right? All these varices, we want to induce the vasoconstriction so that the blood loss comes down. But after that, this is going to be a temporary solution. After that, we have to look at the varices. So if this is esophagus, there are a lot of dilated veins. We will induce vasoconstriction to prevent whatever blood loss that is happening. After that, the choices include endoscopic variceal ligation, where, like, if this is a tortuous vein, we will ligate it at the base so that this tortuous vein will be eventually thrombosed and shed off. And if there is no tortuous vein, no chance of bleeding. We will call it as EVL or variceal ligation, or sclerotherapy, where we will inject some sclerosing agent or fibrosing agent into the varices so that they become fibrosed. So if there is no flow in these fibrosed veins, there is no chance of further bleeding. But what are they asking? What is the first line? First line is trying to cause the splanchnic vasoconstriction so that there is decrease in the ongoing blood loss. So there, traditionally we were using octreotide, but the latest literature says that terlipressin is superior in controlling blood loss than octreotide. So we will be preferring terlipressin. But here terlipressin is not option, so we'll choose octreotide. But again, I just want you to make a note that terlipressin is superior to octreotide. Terlipressin is superior to octreotide. Okay, so that completes this question. We will move to the next question. A 40-year-old female presents with intermittent epigastric pain after meals. Ultrasound shows gallstones. What is the best management option? Observation, orthodeoxycholic acid, laparoscopic cholecystectomy, or ERCP? So in this question, there is no pointer to suspect the possibility of pancreatitis. And because we're not thinking about pancreatitis, I'm not going ahead with ERCP. Okay. But she's having not incidentally noted gallstones. She's having symptomatic gallstones. She's having symptomatic gallstones. Observation cannot be alone enough. Ursodeoxycholic acid is known to reduce the number and the size of gallstones. But patients with symptomatic gallstones, the best treatment, the conservative management can be a way, but what is the question asking? The best treatment. The best treatment is getting rid of the gallbladder through laparoscopic cholecystectomy. This is a relatively a straightforward surgical question. Okay. A 30-year-old male presents with chronic diarrhea, abdominal pain, and weight loss. Colonoscopy reveals continuous mucosal inflammation involving rectum and extending proximally. Which of the following condition explains finally? So what are the findings? Someone presented with diarrhea, abdominal pain, and weight loss. And when the colonoscopy was done, the colonoscopy revealed that there is continuous mucosal inflammation. The term is mucosal inflammation. That means there is no involvement of the whole thickness of the bowel, only mucosa. That is first point. Second, its involvement is seen maximum at the rectum and then extending proximally. So rectum and then extending proximally. Which of the condition is most likely? Okay, first one, Crohn's disease, as we know, it can affect from anus, mouth to anus, anywhere, but the rectal involvement is relatively less likely, right? It most commonly affected part of the bowel in Crohn's disease is going to be terminal ileum. Is going to be terminal ileum. On the other hand, if it is irritable bowel syndrome, there is no mucosal inflammation. It's a functional bowel disorder. You don't find any organic abnormality. There is no mucosal inflammation. Celiac disease most commonly affects duodenum. So all the changes we are getting is seen in duodenum. Why? Because this gluten, right? The maximum amount of gluten is given to the duodenum. As the food bolus passes further down and down, lesser and lesser amount of gluten gets exposed to the mucosa. So maximum gluten exposure happens at the duodenum. So duodenum is the most commonly affected structure. And there also we don't get mucosal inflammation. What are the findings that we are going to get in celiac disease? We will have atrophy of the villi, right? Villus atrophy and crypt hyperplasia. So there villi become shortened, crypt become deeper, crypt hyperplasia and lymphocytic infiltration of the intestinal part, that is duodenum, which is affected. Lymphocytic infiltration. So you'll have plenty of lymphocytes affecting the affected part of the intestine. Of course, there is no involvement of rectum, right? Least likely to be affected. So keeping all these points in mind, the description perfectly fits ulcerative colitis. So we know that in ulcerative colitis, the most commonly affected part is rectum. In case of Crohn's disease, rectum is usually spared. Rectum is usually spared. So we'll stick to our answer, ulcerative colitis. Second thing, what makes me think of ulcerative colitis is continuous involvement. Means there is no skip lesions. If it is Crohn's disease, there will be some patchy involvement. This portion may be involved with inflammation. The next portion, this is skip portion. Again, next portion is involved. So you will end up with skip lesions. You're not getting skip lesions here. There is continuous mucosal involvement. From the point it is involved to whatever extent there is involvement, there is continuous involvement. So everything fits into ulcerative colitis. Pretty good. Good. Which of the following is most specific serological test to diagnose autoimmune hepatitis? Okay, that's a very interesting question. Most specific serological test for diagnosis of autoimmune hepatitis. You know that there are two types of autoimmune hepatitis, the type 1 and type 2. There are two types of autoimmune hepatitis, type 1 and type 2. Of course, type 1 is more common than type 2. Type 1 is more common. Whenever you think of type 1 autoimmune hepatitis, I want SLE to come to your mind, because these are mostly associated with SLE or maybe other autoimmune disorders. What is the most common antibody that we encounter in SLE? The most sensitive antibody is going to be ANA, right? Apart from ANA, you can have anti-smooth muscle antigen antibody and anti-soluble liver antigen antibody, anti-SLA and anti-SMA antibodies. But ANA is the most common antibody that we encounter in patients with type 1 autoimmune hepatitis. The type 2 autoimmune hepatitis, see, as I've already told you, to think of SLE for type 1. Usually SLE presents in second, third decade or reproductive age group, the same age group, same antibody. It's all about SLA. Type 2 typically presents in children where they have this anti-LKM1, anti-liver kidney microsomal 1 antibody, or anti-liver cytosol 1 antibody, anti-LC1 antibody. Among these, we can say that this anti-LKM1 antibody is mutually exclusive. Means if it is present, it is type 2. It is never present in type 1. And if it is present, other antibodies will be absent and you will invariably have type 2 only. So among all these antibodies, you can say that this is highly specific. If it is present, it has to be type 2, and of course it has to be autoimmune hepatitis only, right? But ANA can even be positive in normal individuals. So that makes this the most specific antibody for autoimmune hepatitis. Key points to note: if positive, always suggestive of type 2 autoimmune hepatitis, and if negative, It clearly rules out type 2 autoimmune hepatitis. So keeping those points in mind, what should be my answer? Anti-smooth muscle, yes, it is encountered in autoimmune hepatitis, but in type 1 autoimmune hepatitis. And ANA can be encountered, but in type 1 autoimmune hepatitis, both of them are not specific. Antimitochondrial is not related to autoimmune hepatitis. Anti-LKM1 is associated with type 2 and it is highly specific. It is not encountered in other conditions. So option C will be our right answer for this question. Okay, next. A 30-year-old female presents with chronic diarrhea, abdominal pain, and weight loss. Colonoscopy reveals transmural inflammation with granulomas. What is the most likely diagnosis? Well, few things are there here. Transmural inflammation, that means full thickness of the colon is inflamed and it is a form of granulomatous inflammation. Infectious colitis is not granulomatous. Ischemic colitis is not granulomatous. Ulcerative colitis is not granulomatous. So among these, only granulomatous is Crohn's disease. So we will go ahead with Crohn's disease as an answer. So both transmural word and granulomatous fits into Crohn's disease. Which of the following drug? Okay, just give me a second. Which of the following drug is the drug of choice for inducing remission in moderate to severe ulcerative colitis? Among the given option. It's primarily talking about severe ulcerative colitis. So what can I use to induce remission in severe ulcerative colitis? The biological agents are reserved for those patients where the initial induction attempt with the other drugs has failed. And we know that mesalamine and azathioprine are not potent drugs which can be used for inducing remission in a severe case. In a severe case, maybe we can, after remission is achieved, we can use them for maintenance of suppression, but not for inducing remission. So for inducing remission, steroids, prednisolone or methylprednisolone will be considered as the drug of choice. Many a times steroids may fail. So in that case, we can consider modern biologicals, not before that. Okay, next question. A 50-year-old man presents with jaundice and weight loss. MRI shows a mass at the bifurcation of common hepatic duct. Which of the following is the most likely diagnosis? Okay, this is a rather a straightforward question. The question is talking about what you call as Klatskin's tumor. Mass at the bifurcation of hepatic duct. It's usually Klatskin tumor, which is nothing but a cholangiocarcinoma originating from the duct. So it is going to be a cholangiocarcinoma. Even pancreatic head carcinoma can present as the weight loss, but of course it will be in the at the head of the pancreas, not at the bifurcation of common hepatic duct. Okay. Next question. Which of the following viruses is most commonly implicated in development of hepatocellular carcinoma? Well, remember, even having hepatitis B infection, no active hepatitis is associated with increased risk of developing hepatocellular carcinoma. Hepatitis C also, just having infection is associated with increased risk. Hepatitis A, we know it is not going to be a chronic infection, it's an acute infection. It settles completely, leaving behind no trace of the virus in the liver. So it's not going to increase the risk of hepatocellular carcinoma. So our option D makes the sensible choice here. Both hepatitis B and hepatitis C are risk factors for hepatocellular carcinoma. So what are the risk factors for hepatocellular carcinoma? For hepatocellular carcinoma, the most important risk factor is cirrhosis of liver. More than 85% of hepatocellular carcinomas diagnosed happen in cirrhotic patients, in patients having cirrhosis of the liver. Next is hepatitis B and hepatitis C. Okay. Next, exposure to a toxin called aflatoxin. Aflatoxin. Okay. Then alcohol and smoking. Apart from this, industrial exposure to various drugs. These are all risk factors for hepatocellular carcinoma. These account for more than 95% of hepatocellular carcinoma patients. Right? So we'll stick to option D as our answer. Okay, we will just take a 5 minutes break and then we will connect again to continue with our discussion. I just have a small technical problem. I'll just get that sorted and then we'll continue again. ठीक है, मैंने स्टार्ट कर दिया है. जस्ट चेक वंस की स्ट्रीमिंग हो रहा है या नहीं इन दैट. ओके. Okay, guys. So I guess we are live and the issues are sorted. So just give me a thumbs up if I'm audible to you. Okay. So once you give me a thumbs up, we'll start with the discussion. Okay. Cool. Thanks for patiently waiting. So let's continue with the discussion of the remaining questions. I'll be a little quick and concise this time. So we have in this question a 35-year-old female who presents with weight gain, amenorrhea, and easy bruising. On examination, central obesity, moon face, and striae. So what is the disease that this question is talking about? We are familiar with all these classical symptoms. So what is the disease this question is talking about? Weight gain, amenorrhea, easy bruising, central obesity, moon face, and striae. So what is this talking about? This is talking about Cushing's syndrome, right? We are familiar with all the symptoms of Cushing's syndrome. Just because we're talking about it, few points that I want you to know. Among all the symptoms that we saw, weight gain can be seen in hypothyroidism, polycystic ovarian syndrome, even in Cushing syndrome, right? Then amenorrhea can be seen in hypothyroidism. Then obesity, yes, the same features that we discussed. Even moon face is not a specific finding of Cushing syndrome, to be very frank. It's just the redistribution of the body fat, right? Too much accumulation of fat in the chin region and the facial region produces this classical moon face appearance. So if I want you to pinpoint among all the symptoms listed here, which are more specific towards the diagnosis of Cushing syndrome, what are the symptoms you will mention? Yes, easy bruising and striae. So I want you to remember those symptoms which have high discriminating value. Symptoms with high discriminating value. This is an important examiner's topic for the FMG. For, of course, Cushing syndrome is what we are talking about. For Cushing syndrome. So what are those? That includes number one, thinning of the skin. In Cushing syndrome, high cortisol makes the skin get atrophied or thinned. Thinning of the skin. Second, striae. Now, striae may resemble the stretch marks of obesity, and many of these conditions have obesity. So whether it is striae or stretch marks, how do I differentiate? Well, possible, but striae of more than 1 centimeter diameter is unlikely to be stretch marks. So it is again highly suggestive of Cushing syndrome. And the third one is easy bruisability or easy bruising. Easy bruising, which is not seen in simply obesity or hypothyroidism or polycystic ovarian syndrome and all. So presence of these three symptoms, we will count them as symptoms or signs with high discriminating value. Now this patient of course has all the symptoms that we need for Cushing syndrome, so we will stick to diagnosis of Cushing's. 45-year-old male presents with polyuria, polydipsia, urine osmolality is low, serum osmolality is high. He does not respond to vasopressin. What is the most likely diagnosis? Psychogenic polydipsia, central diabetes insipidus, nephrogenic diabetes insipidus, type 2 diabetes mellitus. So what do you think should be the answer here? Patient has polyuria, polydipsia, increased thirst, increased water intake. Yes, why is it nephrogenic diabetes insipidus? Okay, so in the psychogenic polydipsia, the main problem is increased intake of the water, and as a result, to compensate for that. So basically what happens in psychogenic polydipsia, there is increased water intake. So as I take more water, my plasma or serum gets diluted. The serum osmolality decreases. There will be decrease in serum osmolality, because now I have normal amount of solutes in the blood, but more water added to it. Now, if I have to lose, what should I lose? Solute or water? Of course, water. How will I lose water? The decrease in serum osmolality will result in decrease in ADH production. ADH is antidiuretic hormone which facilitates water reabsorption. So if ADH decreases, then there will be more water excretion. So there will be increased water excretion. So this end, I start with polydipsia. And to make sure this excess water that I'm drinking is lost, I will end up with polyuria. For such a patient, pituitary is absolutely fine, which is capable of producing ADH if we want, and kidneys are also absolutely fine. If we want, the kidneys are able to respond to ADH. So for such a patient, if I give desmopressin, which is a ADH or vasopressin analog, kidneys will respond by increasing water reabsorption, and the polyuria will come down, which is actually harmful for the patient because already he has water overload, and if I give desmopressin, he will have more water overload. But if we give, he responds because his kidneys are perfectly fine. Now in central diabetes insipidus, what is the pathology? In central diabetes insipidus, the problem starts with decreased ADH production because the pituitary is dysfunctional. Central means pituitary is to be blamed. Pituitary is dysfunctional, so the amount of ADH produced is less. Because of that, there is decreased, as the ADH decreases, there will be decreased water reabsorption, and then you can say indirectly increased water excretion. So I am ending up with polyuria because of lack of ADH. And once I have water excretion, I'm losing water, so my serum is becoming more concentrated, or serum osmolality is increasing. And to compensate for that, I start feeling thirsty and start drinking more water, and I end up with polydipsia, increased water intake because of thirst mechanism being activated, and I end up with polydipsia. Now in this patient, kidneys which absorb the water are absolutely fine. The problem is in the pituitary. The lesion is at pituitary. So in that case, if I give ADH, kidneys are fine. So kidneys will respond and I will have improvement in the conditions. But in nephrogenic diabetes insipidus, there is failure of ADH to act at kidneys. So problem is in the kidney. So ADH production is perfectly fine. So I will have, let us say I start with normal ADH. This ADH goes to the kidney to increase the water absorption. But that does not happen. So I will have ADH failure. So ADH action at kidney is reduced. So because of that, I will have increased water excretion, and because of that, I will have polyuria. Reabsorption is reduced, so I'm ending up with polyuria. And as we just learned, to compensate for that, the thirst mechanism gets activated because I will have rise in serum osmolality, and rise in serum osmolality will result in thirst mechanism being activated. So I'll start feeling thirsty and I will have increased water intake triggered by thirst. So I started with ADH inaction. I excreted a lot of water. To compensate for that, I started drinking more. So I started with polyuria and ended up with polydipsia. Now in this patient, if I give ADH, will I be able to reverse this pathology? No, because the ADH still fails at the kidney. So desmopressin is nothing but an ADH analog. Kidneys are already dysfunctional. At the level of kidney, there is resistance to the ADH action. So no matter how much I give ADH, it doesn't work. I will not be able to reverse this pathology. So I will not be able to see the changes. So in this question, they have clearly mentioned that there is no response to vasopressin. So if they mention that there is no response to vasopressin, among these, only one condition that is not going to respond to vasopressin for the polyuria is going to be nephrogenic diabetes insipidus. In type 2 diabetes mellitus, you can have polyuria, polydipsia because of the osmotic diuresis, because you're losing a lot of glucose in urine, and glucose being osmotically active, it will not go alone, it will take water along with that. That's why we are ending up with polyuria. And when I have polyuria, my serum osmolality increases to compensate for that thirst mechanism gets activated, and I end up with polydipsia. So in diabetes, the polyuria is because of loss of glucose, and polydipsia is just a compensatory mechanism. But because I am losing the glucose in urine, the urine osmolality will not be low. So in diabetes, we will have high urine osmolality. And because here the urine osmolality is mentioned to be low, diabetes is clearly ruled out. And among the remaining three conditions, only nephrogenic diabetes insipidus does not respond to ADH. The psychogenic polydipsia and central diabetes insipidus would respond to desmopressin, right? So that's why we will stick to option C as our answer. Okay, next. A 30-year-old female presents with palpitations, tremors, and heat intolerance. On examination, her thyroid is diffusely enlarged. So she is having symptoms of thyrotoxicosis, palpitations, tremors, heat intolerance, right? Suggestive of thyrotoxicosis. And on examination, her thyroid is diffusely, the word is important, it is diffusely enlarged. So what are the findings? We have thyrotoxicosis here, high features of high amount of T3 or T4. And then we notice that the thyroid gland is diffusely enlarged. TSH, here it is mentioned that it is decreased. So T3, T4 is high and TSH is decreased. Radioiodine uptake is increased, means thyroid gland is more active, it is taking up a lot of iodine because it is producing high amount of T3, T4. So what is the most likely diagnosis? Point mentioned here is that TSH is suppressed and there is a diffusely enlarged thyroid gland. So you have diffuse goiter. Thyroid storm is primarily a condition where you have acute thyrotoxic crisis. It just simply indicates that you have high amount of T3, T4, of extremely high amount causing a crisis situation, nothing more than that. If there is toxic multinodular goiter, right, you will not have a diffuse enlargement of the thyroid gland, right? You will have nodular enlargement of the thyroid gland, and radioactive iodine uptake will show increased uptake only in the places where there is nodule present. So only condition among the given options where I will have diffusely enlarged thyroid gland and increased radioactive iodine uptake is going to be Graves' disease. So if it is toxic multinodular goiter, when we look at the radioactivity, we will have wherever there is an active nodule, we will have increased radioactive iodine uptake, toxic multinodular goiter. But if I have Graves is due to thyroid receptor antibodies which are stimulating the TSH receptors, making gland to do more T3, T4 production. The antibody distribution is uniform, so I will have uniform increase in the uptake of the tracers. Diffuse or uniform increase in the radioactive iodine uptake and diffusely enlarged thyroid gland. So because the description is of diffuse, we will stick to Graves' disease as our answer from the question. Next, a 24-year-old male presents with recurrent renal stones, bone pain, and fatigue. Investigation revealed hyperkalemia, hypophosphatemia, and elevated PTH levels. Which of the following is the most likely diagnosis? Okay, so first thing we can rule out from the question is men. Why? Because for the diagnosis of men, A single endocrine organ involvement is not sufficient. Multiple endocrine neoplasia, as the name says, there has to be evidence of multiple endocrine organ involvement. So here it's not multiple. The story is perfectly fitting into hyperparathyroidism. PTH is elevated, calcium is high, phosphate is low. A classical description of hyperparathyroidism, right? It can't be men, because in men I need more than one endocrine organ involvement. Then only I can call it as multiple endocrine neoplasia. So that is ruled out. Now, among the remaining, which fits the bill? Should I count it as primary hyperparathyroidism, tertiary hyperparathyroidism, or secondary hyperparathyroidism? Okay. So give me an example for a secondary hyperparathyroidism. CKD is a classical example for secondary hyperparathyroidism. So exactly what happens in CKD? So in CKD, earlier also spoken about it. In chronic kidney disease, there is impairment of excretion of sulfates and phosphates, and these sulfates, phosphates, and other similar molecules are accounting for the anion gap that we are getting in AK and CKDs. Otherwise, the main impairment is H plus secretion and bicarbonate reabsorption, similar to renal tubular acidosis. But why I'm getting high anion gap metabolic acidosis in CKD? It's because of impairment of phosphate and sulfate and other acid anion secretion. So they are accumulating. So in CKD, the main problem with with parathyroid starts with the phosphate accumulation. So in CKD, the problem is increase in the phosphate. So as phosphates increase, they stimulate the parathyroid gland to increase the parathyroid hormone release. And once there is release of the parathyroid hormone in CKD, this parathyroid hormone may go to the bones and try to bring the calcium out. Okay, that's clear. Second, so here phosphate is expected to be high in the, sorry, we are talking about secondary. So I just wrote it here. So in the secondary, like CKD, we're expecting high phosphate, high parathyroid hormone, right? And again, another finding that we are going to get in CKD is for the absorption of calcium in the gastrointestinal tract, I need vitamin D. And this vitamin D exists in an inactive form called 25 hydroxy cholecalciferol that needs to be activated to 125 hydroxy or dihydroxy cholecalciferol. That's the most active form of vitamin D. For its conversion, we need an enzyme called 1-alpha hydroxylase, which is produced by kidneys. And in CKD, if the kidneys are dysfunctional, I may not be able to produce this 1-alpha hydroxylase. So I will not have sufficient quantities of active form of vitamin D. And vitamin D is required for the calcium absorption in the gastrointestinal tract. So less vitamin D, less calcium absorption. So I can have low calcium as well. So this parathormone is now trying to increase the calcium and decrease the phosphate. Clear? So we're expecting hypercalcemia and hyperphosphatemia in secondary. In primary, what happens? In primary, the main pathology is the parathyroid gland itself. So gland produces high amount of parathormone. There is increased PTH production because the gland is overactive. Either it is hyperplastic or there is a parathyroid producing tumor. And as the parathyroid hormone levels increase, it will increase phosphate clearance and increase calcium reabsorption. So that will result in increase in serum calcium values and decrease in phosphate values. Decrease in phosphate values. So this classical picture of hypercalcemia and hypophosphatemia is encountered in primary hyperparathyroidism. In secondary, we are expecting hyperphosphatemia, hypocalcemia, and high PTH. So here, because basically low calcium and high phosphate is triggering parathyroid hormone to produce more PTH. Here, high PTH is increasing the calcium release from bones and from the GIT calcium absorption and excretion of the phosphate. So we'll have hypophosphatemia and hypercalcemia in primary. So here they have mentioned hypophosphatemia and hypercalcemia. Others, as we know, are typical symptoms of hypercalcemia indeed. So we will stick to primary hyperparathyroidism as our answer here. Okay, next, a 42-year-old woman presents with fatigue and weight gain and constipation. On examination, she has bradycardia and delayed relaxation of tendon reflexes. So now what do you think? By now, we are talking about a women, middle age, weight gain, fatigue and constipation. Bradycardia also. So already we're thinking of a possibility of hypothyroidism. All these symptoms can be explained. And then examiner gives you a strong clue. The strong clue is delayed relaxation of deep tendon reflexes, which is also called as Voltman sign. Voltman sign. Delayed relaxation of deep tendon reflexes, which is classically seen in severe hypothyroidism, right? So that prompts me to think of the diagnosis of hypothyroidism. Now, on lab evaluation, the TSH is 18, the lab normal is 0.4 to 4, and free T4 is low. So hypothyroidism with, of course, low free T4 and TSH which is high. So what is the diagnosis here? Is it primary hypothyroidism, secondary hypothyroidism, or tertiary? So thing to note here is that when I say primary, in any endocrine disorder, the gland which is supposed to produce that hormone is the site of problem. So if I have to say primary hypothyroidism, then problem is in the thyroid gland. When you say secondary, one level above it, which is regulating. So we know that thyroid gland produces T3 and T4. Its production is stimulated by the pituitary gland, which produces thyroid stimulating hormone, which stimulate the thyroid gland to produce T3, T4. And TSH production is regulated by the hypothalamus, which releases this so-called thyrotropin releasing hormone, which stimulates the pituitary gland to stimulate or produce TSH. So if the problem is in the thyroid gland, it is primary. If the problem is in the pituitary gland, which is the next level of regulation, we will call it as secondary. If the problem is in the hypothalamus, it will be called as tertiary. So in case of primary hypothyroidism, TSH and TRH will be normal, but it is the thyroid gland which is dysfunctional, not producing the sufficient T4 or TSH. Always think of primary when if the examiner is talking about primary, always think about the main gland which is concerned with release of that particular hormone. Clear? Okay. So if it is primary, T3, T4 will be low because the gland is dysfunctional. But when I look at the TSH, that won't be low. In fact, because all these will have negative feedback, that is lost. So I will have increase in TSH and I will have increase in TRH. A simple way to remember this is that only one hormone will be abnormal, that is thyroid hormone will be low. The TSH and TRH will not be low, that they are high. So in primary, only one will be low. In secondary, two hormones will be low. Secondary, the problem is in the pituitary. That means my TSH will be low. Pituitary is not able to produce sufficient TSH. Because of that, my thyroid hormone is not producing sufficient T3 and T4. So that's why I have low T3 and T4. What will happen to the TRH? Yes, because the TSH will have a negative feedback. T3, T4 will have a negative feedback and the TRH that is lost. So I will have increase in TRH. So in the secondary, two hormones are low, right? Thyroid and TSH. In tertiary, the problem is in the hypothalamus. So in tertiary, the TRH production itself is low. So because of that, now I have low TSH production, and because of that, I will have low T3 and T4 production. So here all the three are low, right? So the easiest way not to get confused in the exam between primary, secondary and tertiary is considering primary has only one low, secondary has two lows, tertiary has three lows. Primary, the main organ is the responsible organ. Secondary, the next main organ, next regulator. Third, tertiary is the final regulator abnormal. So in this question, free T4 and free T4 is low and TSH is high. So this question is not talking about TRH, so we can eliminate this chamber, just this part of the table. Okay, now let's think about it. What are we noticing? The T4 is low, TSH is high. So in what conditions I can get that? Yes, in primary. If it is secondary, TSH will be low. If it is tertiary, TSH will be low. So in only primary, we have high TSH. That means our diagnosis is going to be this hypothyroidism is primary hypothyroidism. And what is the most common cause for primary hypothyroidism? So please remember, the most common cause for primary hypo once upon a time used to be iodine deficiency. After the fortification of salt with iodine, it's no longer a cause. So what is it now? It is Hashimoto's thyroiditis. Hashimoto's thyroiditis is the most common cause for primary hypothyroidism. And within the Hashimoto's thyroiditis, it's an autoimmune disorder, so we know there are antibodies. The most common antibody that we are going to get in Hashimoto's thyroiditis is anti-thyroid peroxidase or anti-TPO antibodies are the most common antibodies. So now the answer becomes very clear that we are expecting anti-TPO antibodies in this case because it is primary hypothyroidism. I also told you to remember this sign. Delayed relaxations of deep tendon reflexes. It's because of myoedema or muscle edema. The muscles are edematous just like how you have mixed edema. So when you hit it for the reflex, contraction happens, but the relaxation will be slow because of myoedema. Anti-insulin antibodies are seen in type 1 diabetes mellitus. Right? Anti-GAD again are seen in type 1 diabetes mellitus. Anti-TSH receptor antibodies or TRAB, thyroid receptor antibodies are seen in patients with Graves' disease, which is a thyrotoxic condition. Here patient has hypothyroidism. So what fits the bill is anti-TPO antibodies. Next, a 35-year-old man presents with polyuria polydipsia. His serum sodium is 132, urine osmolality is 180. Plasma osmolality is 310. After administration of desmopressin, urine osmolality increases to 400. What is the most likely diagnosis? Nephrogenic diabetes insipidus, psychogenic polydipsia, central diabetes insipidus, type 2 diabetes mellitus. So what do you think is the diagnosis? Polyuria polydipsia, serum sodium is 152, urine osmolality is 180, and plasma osmolality is 310. After administration of desmopressin, urine osmolality increases to 400 milliosmoles. What is the most likely diagnosis? So urine osmolality has seen a jump from 180 to 400 after administration of desmopressin. So can this be nephrogenic diabetes insipidus? Can this be nephrogenic diabetes insipidus? Yes, why not nephrogenic diabetes insipidus? Because nephrogenic diabetes insipidus won't respond to desmopressin. So here there is response to desmopressin. So this can't be nephrogenic diabetes insipidus. Right. Why is this not type 2 diabetes mellitus? I can have polyuria polydipsia and type 2 diabetes mellitus. Yes, it is not diabetic because in diabetes the urine osmolality will be high. Why? Because in diabetes I'm excreting sodium in urine, glucose in urine, which is an osmotically active substance. So that's why whenever we are dealing with the polyuria question, the first thing I want you to see is the urine osmolality. Urine osmolality. How do you define polyuria? Polyuria is defined as urine output more than or equal to 40 ml per kg per day. So a 50 kg individual, 40 ml per kg, it's like 2000 ml or 2 liter per day. If someone is passing more than 2 liter per day, if he is weighing 50 kg, it can be counted as polyuria. Then we have to look at the urine osmolality. What is the serum osmolality? Serum osmolality is around 280 to 295. Right? Let us take the rough cutoff as 300. If urine osmolality is more than serum, that means there is secretion of an osmotically active substance in the urine. So if it is more than 300 milliosmoles per liter, it indicates presence of some osmotically active solute. So we'll call this as solute diuresis, as in case of hyperglycemia or diabetes, or use of another osmotic agent which is mannitol, right, or use of diuretics which will increase sodium loss, potassium loss in the urine, and also water loss. So you'll have polyuria, but because you're losing sodium, potassium, you will have high urine osmolality. If the urine osmolality is less than 300, if it is less than 300 milliosmoles per liter, it means it is dilute urine, right? What you're losing is mainly water, not much of solute. So it's not glucose, it's not the electrolytes because of diuresis, it's mainly water. So now we have differential diagnosis of psychogenic polydipsia and diabetes insipidus. Now, how do I differentiate further? Depends on various factors. One of the common investigations that can help me to take things further is ADH. See, in case of polydipsia, what is the main pathology? Increased water intake, right? So as there is increased water intake, the serum osmolality decreases. Right now, should I reabsorb more water from the kidney or lose more in the urine? I'm drinking a lot. Whatever extra I'm drinking should be lost in the urine. I should not reabsorb. So I need to stop reabsorption. And who is reabsorbing? ADH. So I need to block or reduce ADH. So decreased water intake leads to decreased ADH. Here, kidneys are fine, pituitary is fine. The ADH is decreased in response to increased water intake. Main problem is increased water intake. Now that ADH decreases, I will increase water excretion. So whatever extra I am intaking will be lost in urine. On the other hand, what happens in case of central diabetes insipidus? In CDI, pituitary is the problem. Pituitary is not able to produce ADH. So we'll already have low ADH because of pituitary problem. Because of low ADH, I'm not able to reabsorb water in the kidney. I'm losing a lot in the urine. And as I lose a lot in the urine, it's water that I'm losing, no other solutes that I'm losing. So my urine will be having low osmolality, less than 300 milliosmoles. And as I lose water, to compensate for that, I drink more. So I will end up with polydipsia. But in nephrogenic diabetes insipidus, what happens? Kidney produces, pituitary produces sufficient ADH, but kidneys fail to respond. Kidneys are not able to absorb water according to that. So because of that, serum osmolality is not getting normalized, right? It remains high. And to overcome the resistance of the kidney, now the pituitary will produce even more ADH. So we'll have increase in the ADH in nephrogenic diabetes insipidus. So now in this case, if I do this ADH values, if ADH value is high, what does it indicate? Clearly nephrogenic diabetes insipidus. If ADH values are low, it could be central or polydipsia. That is one approach. Another approach is doing water deprivation test. Let us see what happens in water deprivation test. We stop the patient from drinking water. So if I stop this patient from drinking water, no more excess water intake, so no more suppression of the ADH, ADH will become normalized, water reabsorption will increase, and polyuria will get resolved. Because here the main problem itself was excess water intake. I solved it, right? In central diabetes insipidus, no matter how much water intake reduction I do, anyway ADH production will not increase. I will continue to have polyuria. In nephrogenic diabetes insipidus, no matter how much water intake I decrease, my pituitary may be able to produce proportionately more ADH, but kidneys cannot respond, right? So that is one more way of interpreting it. Then the third is administration of desmopressin. So here kidneys are fine, pituitary is fine. If I administer desmopressin, because kidneys are fine, they will respond by increasing the water reabsorption. In central diabetes insipidus, yes, I have lack of ADH, I give it, kidneys will respond. But here, kidneys won't respond, right? So in this scenario, what have they mentioned? After administration of desmopressin, the osmolality increased to 400 milliosmoles per kg. So what is the most likely diagnosis? So it means it is not going to be nephrogenic, which we have already ruled out. We have already ruled out that it is not diabetic, because in diabetic the urine osmolality will be high, usually higher than serum. Now I'm only stuck between these two. So what do you think it is? Because there is no mention of, why not psychogenic polydipsia? Psychogenic polydipsia also responds to desmopressin. If I give desmopressin, kidneys are fine, so they will increase the water absorption. Yes, all of you mentioned the right answer, but why not psychogenic polydipsia? What is the clue in the question? Remember, in psychogenic polydipsia, main problem is I'm drinking a lot of water. So if I'm drinking a lot of water, what will happen to my serum sodium values? There will be plasma dilution. So serum sodium values will decrease. I may end up with hyponatremia. Of course, after that, I will pee more to get this serum sodium value normalized. Right, so it's basically, it's like I'm adding water into this plasma, I'm diluting it, so I will end up with hyponatremia. Once I excrete more water, the dilution is corrected, sodium becomes normalized. We are not expecting, I'm either seeing hypo or eunatremia in case of psychogenic polydipsia. We are not expecting hypernatremia, but here we are seeing hypernatremia. That can happen in diabetes insipidus, because I keep losing water. And if I'm not able to drink appropriately, right? If I'm losing 1 liter water, and if I don't drink 1 liter water, my plasma starts becoming concentrated and I end up with hypernatremia. In a condition where patient has easy access to water, we don't expect hypernatremia, because as the serum osmolality starts going up because of urinary loss of water, my thirst gets triggered and I keep drinking and I keep compensating. But many times what happens, patient is bedridden, he doesn't have access to water, they may not be able to quench their thirst, they may not be able to normalize their serum osmolality and serum sodium values. So hypernatremia here is a potential clue that it is not polydipsia, rather central diabetes insipidus. Yes, ideal for the diagnosis, we need the urine osmolality to increase to more than 800. When we are in the gray zone, like there is increase but not more than 800, we are stuck at an uncertain diagnosis. So for there again, we need more detailed investigation, or take other pathways like the copeptin assay or the urinary, or the MRI pituitary bright spot. We have to take the other pathways. Today in practice, water deprivation test is not routinely followed. But from the story mentioned, Usman, you brought a very important point. Yes, if it increases more than 800, we can have a definitive diagnosis that it is central diabetes insipidus. Ideally, we need the urine osmolality to jump more than 800. But again, looking at the sodium values, okay, remember, even in patients with the psychogenic polydipsia, it will jump to more than 800. It will jump to more than 800. So we'll count it as central diabetes insipidus. Okay, next one. 60-year-old male with type 2 diabetes mellitus is on metformin and glimepiride. He presents with dizziness, sweating, and confusion. Blood glucose is 40 milligrams per deciliter. What is the most appropriate immediate treatment? Type 2 diabetes on metformin and glimepiride. He presents with dizziness, sweating, and confusion. His blood glucose is 40 milligrams per deciliter. Okay, why not oral glucose? Why not glucagon injection? Of course, hypoglycemia will not give insulin, I agree, but why not ABC? So remember, when we are dealing with hypoglycemia, we will have grades of hypoglycemia, and our treatment depends on the grades of hypoglycemia. So what are the grades of hypoglycemia? Grade 1 hypoglycemia and grade 2 are defined. Grade 3 is not well defined. What is grade 1? Your blood glucose levels in the range of 55 to 70 milligrams per deciliter. More than 70 milligrams per deciliter will not count it as hypo. 70 plus is not hypo. 70 to 55 is grade 1. And blood glucose levels less than 54 milligrams per deciliter, we will call it as grade 2. And what is grade 3? What is grade 3? Any individual, any degree of hypoglycemia, if he required a third person to assist for him to come out of hypoglycemia, will be considered as grade 3. It may be grade 1 or grade 2, but patient is not able to self take care of it. Is not able to take care of himself. So any degree of hypoglycemia where patient needs assistance to manage hypoglycemia will be considered as grade 3. So in this question, what should I count it as? Grade 1 or 2 or 3? What is it? So point to note from the question is that blood glucose wise, he is grade 2. It is less than 54. So it is grade 2. But he is in a confused state, right? Symptom wise, he is in confusion. So he'll not be able to take care of himself. Confused, drowsy, they're all grade 3. So here we have grade 3 hypoglycemia. And in terms of treatment, the grade 1 and grade 2 are usually managed with. So the first line management will be oral glucose, because these patients are conscious, they're self able to manage. So we'll give them oral glucose, 20 grams of anhydrous glucose or its equivalent in other form like sucrose or maybe a chocolate or something, every 15 to 20 minutes till blood glucose values are more than 70 milligrams per deciliter. But anytime he switches down to the grade 3 where he becomes drowsy or something, again we have to go with IV dextrose. IV dextrose 25 to 50% is the way to manage grade 3 hypoglycemia. We will not be able to manage them with oral agents. So here, because this is grade 3, oral glucose is not sufficient. Glucagon, you may ask, sir, we can use glucagon injection. Glucagon injection is considered as an alternative to grade 1 and 2. Yes, 25 to 50% dextrose. Glucagon is considered as an alternative for grade 1 and 2. Why is it not a good idea to use it for grade 3? Remember, the glucagon action is influenced by insulin. Insulin has a suppressive action on glucagon. So glucagon's actions are countered by insulin. So when insulin or insulin secretagogues are the cause for hypoglycemia, glucagon may not be very effective. So it is more convenient when you still have a reasonable blood glucose value and you're not becoming drowsy or confused. One may consider using glucagon as an alternative to oral glucose, but when you are in a critical condition, IV dextrose is the way to go forward. Okay. Next, a 24-year-old female presents with heat intolerance, palpitations, and weight loss despite increased appetite. She is noted to have lid lag and pretibial mixed edema. Which of the following is the definitive treatment for her condition? So, what's the diagnosis here? All the symptoms are pointing towards thyrotoxicosis. The most common cause for thyrotoxicosis is currently the most common cause for thyrotoxicosis or hyperthyroidism, if the drugs are ruled out, means iatrogenic causes are ruled out, like if I am giving too much of thyroid hormone, that's definitely going to cause thyrotoxicosis. But if these causes are ruled out, then what is the most common cause? Graves disease. Graves disease is the most common cause for hyperthyroidism. So all these symptoms we can presume to be of Graves disease. In fact, age and gender also fit into it. Graves disease is more common in females, typically more common in young or middle-aged. So everything fits into Graves. So let me presume it as Graves. And then they're asking which of the following is the definitive treatment for our condition. What is the pathology in Graves disease? Graves disease is an autoimmune disorder where there is production of thyroid receptor antibodies or thyroid stimulating immunoglobulin. So basically body is producing antibodies which stimulate the TSH receptors on the thyroid gland. So these traps will exactly function like the TSH, because here we will have this TSH receptors, and these traps go and bind and stimulate, and they tell the thyroid gland to produce more T3 and T4. So there will be increased T3 and T4 production because the gland is being tricked to believe that TSH has come, but what has come is the thyroid receptor antibodies. Okay. Now I can give drugs which block the production of T3 and T4, like methimazole, carbimazole. That's one way to treat it. But that only deals with the thyroid gland's activity. It will not deal with this thyroid receptor antibody production. So I can give steroids to suppress, but not highly effective. What else we can do? Propranolol. This increase in T3 and T4, they cause sympathetic overactivity, right? They will increase sympathetic receptors, and because of that we will have sympathetic overactivity, and this overactivity explains many symptoms of excess thyroid hormone that include palpitation, heat intolerance. Heat intolerance can be explained by metabolic rate, but palpitations, then hypertension, especially hyperthyroidism has systolic hypertension, tremors, these can be explained by sympathetic overactivity. So if I give propranolol or other beta blockers, I can stop or inhibit the sympathetic overactivity that is happening here, right? But still T3 T4 production will continue to be excess, and that T3 T4 excess will increase the metabolic rate, right? So two things that happen here is, one is increased metabolic rate because of T3 T4, and second one is sympathetic overactivity. The tremors, palpitations, sweating, they are all related to sympathetic overactivity. Increased metabolic rate leads to the weight loss, right? That will not still respond if I just give propranolol. So propranolol only addresses the sympathetic symptoms of thyrotoxicosis. Nelson Vani, very good, very good. So here the more definitive treatment will be, see again, methimazole or carbimazole or propylthiouracil is the first line treatment for most patients with Graves, because at least few percentage of patients in 12 to 18 months of treatment, the antibody production will slowly regress by itself, and once this antibody production decreases, I don't have to inhibit the thyroid gland from producing T3 T4 anymore, because it will now be doing the normal work and problem gets solved. But for many patients, despite 12 to 16 months of anti-thyroid drugs and waiting for the immunity to fade, it doesn't. So in that case, either I have to get rid of the thyroid gland surgically or do radioactive iodine uptake ablation. So what do we do in radioactive iodine uptake ablation? We give radio iodine, which is having high radioactivity, and because thyroid gland is capable of trapping the iodine, it traps a lot of iodine, gets more exposed to radiation and gets destroyed. After this, patient ends up becoming hypothyroid because now the thyroid gland is destroyed, and we will start them on replacement. It's more safer to be hypothyroid and be on levothyroxine replacement than be on these antithyroid drugs which have side effects like agranulocytosis and hepatotoxicity. So because in this question they're asking what is definitive, of course radioactive iodine ablation. But if they're asking what is initial treatment, initial treatment would be antithyroid drugs. Antithyroid thyroid drugs. Yes, as you mentioned, if the patient is in pregnancy, what can we do? If patient is in pregnancy, radioactive iodine ablation cannot be done. Yes, thyroidectomy is a choice, or giving anti-thyroid drugs. If I'm giving anti-thyroid drugs, what is the drug of choice for first trimester of pregnancy? Can I give methimazole in the first trimester of pregnancy? What side effects or teratogenic effects methimazole is associated with? Methimazole is associated with what you call as, yes, propylthiouracil is considered as the drug of choice because methimazole is associated with aplasia cutis if exposed in the first trimester. Aplasia cutis, where there is hypoplasia or improper development of skin, mainly in the scalp, but other areas as well. And it is also associated with neutropenia, not a teratogenic effect, but it's one of the side effects, right? So we'll prefer propylthiouracil. But from second trimester onwards, we should ideally switch to the methimazole or carbimazole from propylthiouracil. Why? Because propylthiouracil has high risk of PTU, is associated with increased risk of hepatotoxicity, and pregnancy itself is a hepatotoxic condition. Pregnancy itself, yeah, choanal atresia also is a hepatotoxic condition. So we do not want to keep a hepatotoxic drug in a pregnant individual. Like she may develop the acute cholestasis of pregnancy, or the patient may develop HELLP syndrome and all, and having another hepatotoxic drug go along with that is not something that we want to do. So it is more wise to switch from the PTO to methimazole or carbimazole from second trimester onwards. Good. Okay, next. A 50-year-old male presents with headache, visual disturbances, and sexual dysfunction. MRI shows a large pituitary tumor compressing optic chiasm. Serum testosterone is low, while prolactin is normal. Which of the following hormone deficiency is most likely responsible for this symptoms? So, headache and visual disturbance can be explained from the tumor compressing the optic chiasm. It need not be a functional tumor, even a non-functional tumor which does not produce a hormone can cause this. So, that's not a big deal, right? But the sexual dysfunction, this can only be explained by hypogonadism, right? Reduced activity of the testicles or ovaries in male and female respectively. And as expected, here it's a male and the testosterone is low. Okay. Now this low testosterone can be a side effect of high prolactin, or it could be because of lack of LH and FSH. Because prolactin is also known to suppress the production of testosterone, right? It also causes some degree of hypogonadism. So in males, it often causes lack of libido. But here they have clearly mentioned that the prolactin is normal. So that rules out hyperprolactinemia as the cause for the hypogonadism. So that is ruled out. So what is left now? Lack of LH and FSH. So we know that pituitary produces the gonadotropins, that is LH and FSH. These will stimulate the testicles to produce testosterone for male, estrogen, progesterone for females, and its control from the hypothalamus is through the hormone GnRH, gonadotropin releasing hormone. So LH and FSH are our gonadotropins. These are gonadotropins, and to release these gonadotropins, hypothalamus has to secrete gonadotropin releasing hormone, and in response to gonadotropins, gonads respond by releasing their hormones. So if I'm talking about male, it is going to be testosterone. So if LH or FSH is low, I will have low testosterone, right? So we'll call it as hypogonadotropic hypogonadism. So here hypogonadism is happening because of low gonadotropins. On the other hand, we can also have hypergonadotropic hypogonadism. Like for example, the testis itself is damaged, So I have low testosterone because of that. But because now I'm taking away the negative feedback that earlier I had on LH and FSH, the LH and FSH will increase. So we'll have hypergonadotropic hypogonadism. But in this question, the story is classical of hypogonadotropic hypogonadism. We have low LH and FSH. Okay, next. A 44-year-old woman undergoes thyroidectomy for papillary carcinoma. Post-operatively, she develops perioral tingling and muscle cramps. Her calcium is 7.2. What is the next best step in management? Okay, so this is a classical, well-known complication of thyroidectomy because parathyroid glands are anatomically closely associated with thyroid gland. Thyroidectomy often can lead to loss of parathyroid gland tissue as well, and we can develop hypoparathyroidism, right? Should I count it as primary or secondary? Primary, because here there is injury or damage to the parathyroid gland itself, not something else. So we have primary hypoparathyroidism because of the surgical excision of the parathyroid glands. This results in, of course, low PTH. Low PTH results in low calcium and high phosphates. High phosphates. Now, whenever we have symptomatic hypocalcemia, except in patients with hysterical hyperventilation or simply hyperventilation, except in those cases, if they are having symptomatic hypocalcemia, right? This is hypocalcemia. If they are symptomatic, we have to treat them with IV calcium gluconate. And if they are asymptomatic, we can try to slowly build up the calcium values by giving supplementation and treating the underlying cause. If they're asymptomatic, mainstay will be treat cause, then give oral calcium supplementation to facilitate increase in this calcium absorption, because calcium absorption depends on vitamin D. I need to give vitamin D supplementation. This is the way I'm going to bring calcium values in this patient. But if they're symptomatic, I always need to quickly correct the calcium values. So I would have to go with IV calcium gluconate. IV calcium gluconate. So in this case, the patient is having symptoms. There is perioral tingling and muscle cramps. So because it is symptomatic case, we are going ahead with intravenous calcium gluconate. Okay, next. A 30-year-old man with family history of MEN2A should be screened for which of the following endocrine tumors? So indirectly, you should tell me what is the most commonly affected organ. Mr. Arpit, absolutely right. So a 30-year-old man with family history of MEN2A syndrome should be screened for which of the following endocrine tumors first? Tell me. Which of the following should be screened first, or what is the most common manifestation? Okay. So as we know, see, this is one point I want you to clearly notice now or notice today, that MEN2A is, we all know that it is due to red proto-oncogene mutation inherited as an autosomal dominant condition. The involvement here is of the thyroid gland, where there is patient presents with medullary thyroid cancer. Apart from that, they are prone to develop pheochromocytoma and hyperparathyroidism. And to remember this, I had given the mnemonic in the classes. What is the mnemonic? MPP. Madhya Pradesh is progressing. Madhya Pradesh is progressing, where M stands for medullary thyroid cancer, P for pheochromocytoma, another P for parathyroidism. Right? I've arranged them in the sequential order of appearance. So overall, the most common manifestation is medullary thyroid cancer. When do they present with cancer? By third decade, almost 100% of them will have developed medullary thyroid carcinoma. So that's why thyroidectomy within the first year of age of life itself is recommended. Means don't even wait for the child to become 2-year-old or 3-year-old. Within the first year of life, get rid of the thyroid gland if you know that patient has the MEN 2A, because by third decade 100% of them will have medullary thyroid cancer, and that doesn't mean that all 100% will develop in third decade. Many of them will develop first or second decade itself, right? So overall, by the time the individual completes third decade of life, 30 years of life, he would have developed, almost all of them would have developed the medullary thyroid cancer. So that's why if I have to screen, what I should be screening for, I should be screening for medullary thyroid cancer. If not, thyroidectomy is not done. If given a choice for this patient, I would go ahead with the medullary thyroidectomy after confirming the presence of the ret proto-oncogene mutation. There's a strong family history. We'll go ahead with the ret proto-oncogene mutation. If mutation is present, we know that it is meant to be better to get rid of the thyroid gland, because we also know that it is autosomally dominant inheritance. Okay, so remember the components of MEN2A with the mnemonic Madhya Pradesh progressing. Yes. Now, the next question. A 65-year-old female with type 2 diabetes is admitted for hyperglycemic hyperosmolar state. Which of the following is most important initial step? I can say the same thing for the DKA question also. For a DKA question also, Nelson money, yes. But given a choice, ideally doing it within 1 year is more ideal. Not to wait for the individual to enter into second or third decade, as early as possible is ideal. Yes, for DKA and HHS, the real problem, the biggest problem the patients have is fluid deficit. Why do they have fluid deficit? Because of this increase in the blood glucose level. Glucose is osmotically active, so we will have loss of glucose in the urine. With that glucose, we will be losing a lot of water because glucose is osmotically active. So because of that, I will have severe fluid deficit in the body, up to 6 liter in the diabetic ketoacidosis, and more than that 9 to 12 liters in patient with HHS. So you can think about getting the blood glucose level and all control later. First, fill the fluid deficit. So fluid is the first choice. After fluid deficit is corrected, then you can think about the insulin, and you may have, because now that you are giving insulin, there is a shift of potassium from extra to intracellular compartment, so you might have to consider potassium supplementation, right? Of course, here we will not be giving glucagon, and of course subcutaneous insulin is not something that we will be doing in both DKA and HHS. Even if after the fluid, when I start about talk about insulin, it has to be IV. So B will be our right answer. Okay, a 55-year-old woman presents with truncal obesity, hypertension, and purple stripe. So already story, you know what it is talking about. 24-hour urine-free cortisol is elevated. So a screening test is done. Screening test clearly says that there is high cortisol. High-dose dexamethasone suppression test fails to suppress cortisol levels. Plasma ACTH levels are undetectable. What is the most likely source of excess cortisol? What is the most likely source for excess cortisol here? Okay, so this high dose dexamethasone suppression test, does it help us to differentiate between the adrenal cause for excess cortisol and an ectopic ACTH producing tumor? Okay, so here in this question, the plasma ACTH levels are undetectable, right? It's undetectable. So there can't be an ectopic ACTH producing tumor. If ACTH producing tumor is the reason, I will have high ACTH, right? Similarly, if pituitary gland or hypothalamus are the problems, I will still have high ACTH, because now they can be comfortably ruled out. So when you look at this whole HPA axis, right? Hypothalamo pituitary adrenal axis, I have hypothalamus producing corticotropin releasing hormone, right? Hypothalamus is producing corticotropin releasing hormone, which will stimulate the pituitary gland, and pituitary gland will produce ACTH. ACTH will stimulate the adrenal glands to produce cortisol. Now the adrenal cortex will produce cortisol. So if I have a pituitary tumor which is producing ACTH, and because of high ACTH, adrenal gland is merely responding, I will have serum ACTH levels to be high. Okay, let us say that I don't have a problem in the pituitary, but rather hypothalamus. There is a hypothalamic tumor which is producing CRH. High CRH leads to high ACTH leads to high cortisol. Fair. So in that case, again, I will have high ACTH. But in this question, the ACTH levels are undetectable or suppressed. So it probably because of this cortisol having the negative feedback on ACTH production and hypothalamic CRH production. So that means the problem is in the adrenal glands itself. An adrenal tumor or adrenal hyperplasia is leading to high amount of cortisol production. This cortisol is suppressing ACTH. So that's why I have low or undetectable ACTH and high cortisol. Yes, good. So we are going to stick to our answer of adrenal glands. Yeah, so when we try to suppress in endocrinology, when we give a suppressing agent to suppress the secretion of hormone from a target tissue, usually suppression is more likely if the source is the main gland. Means, like for example, if there is excess ACTH, as Nelson Wani mentioned, like if the source is high ACTH, this can be coming from either pituitary gland or an ectopic source or an ectopic source. It is more easy to suppress the pituitary gland with high amount of dexamethasone. It will be more difficult to suppress this ectopic source. Ectopic source will be difficult to suppress because pituitary is designed to take this negative feedback from the glands, right? The cortisol will have the negative feedback normally. So if there is a tumor which is producing it, if I give too high dose of dexamethasone in this place of cortisol, I may be able to suppress it. It is relatively more easier to suppress pituitary than an ectopic source because an ectopic source is not designed for the negative feedback. Okay, so anyway, in this question, we are not differentiating between the pituitary source of ACTH and an ectopic source of ACTH. We are rather different. We already know that the ACTH level is low. So we know that pituitary as well as ectopic source of ACTH are ruled out. So we are only looking at adrenal gland. Okay, next. A 50-year-old male with type 2 diabetes presents with an HbA1c of 9.2%. He is already on maximum tolerated dose of metformin and glimepiride. What is the most appropriate next step in management? A 50-year-old male with type 2 diabetes mellitus presents with HbA1c 9.2. Metformin and glimepiride is already on fully tolerated dose. What is the next most appropriate step in the management? Okay, good, but Said, why not insulin? Why not insulin? Tell me indications for insulin. Indications for insulin in type 2 diabetes mellitus. Type 1, though, the disease itself is the indication. So what are the indications here? The first indication is symptomatic diabetes mellitus, right? So if patient is having symptoms of hyperglycemia, what are the symptoms of hyperglycemia? Polyuria, polyphasia, polydipsia, right? 3 P's of diabetes. I'm having polyuria, polyphasia, polydipsia, and also weight loss, then it is indicated. Second, hyperglycemic crisis. What are hyperglycemic crisis? DKA and HHS. I have to start insulin. Hyperglycemic crisis, that includes DKA and HHS. Good. The third, with respect to HbA1c as a value, HbA1c more than or equal to 10, we can consider insulin. In this case, HbA1c is not 10 plus. I don't find any other reasons for me to think of insulin because there is no mention of any of the hyperglycemic symptoms. The patient is not in the crisis situation, DKA or HHS. So we don't have to think of insulin, right? And already the question mentioned that the patient is on maximum tolerated dose of metformin and glimepiride. So further increase means invitation of side effects, because it's already on maximum tolerated dose. He will not be able to tolerate more than this, right? Insulin, we are not going ahead because the HbA1c is not more than 10 and there are no other indications in this case. So I'm left with pioglitazone and empagliflozin as this choice. Given a choice, I would go ahead with empagliflozin because they bring added benefits. Right, SGLT2 inhibitors reduce the long-term cardiovascular mortality, reduce the rate of progression of CKD or decline in GFR because of diabetic nephropathy. So keeping the added advantages in mind, we will go ahead with empagliflozin over pioglitazone. Okay, and that is what even the latest ADA guidelines recommend. Okay, next. A 34-year-old female with Graves' disease develops agranulocytosis after starting methimazole. What is the most appropriate next step in the management? Continue methimazole at lower dose, switch to propylthiouracil, radioactive iodine ablation, or subtotal thyroidectomy. So the point to note here is, though propylthiouracil is not as notorious as methimazole or carbimazole for causing agranulocytosis, some degree of cross reaction is often possible, and propylthiouracil may contribute to further worsening of agranulocytosis. That's why switching is not considered as a wise choice. And continuing definitely at even lower doses is not considered as wise choice. So to choose between radioactive iodine ablation and subtotal thyroidectomy, radioactive iodine ablation makes more sense because it is relatively less invasive, not surgical. So we'll go ahead with option C. Why am I not choosing propylthiouracil? Because though less likely to cause agranulocytosis, some risk is always there with propylthiouracil also. So instead of taking that risk, we would go ahead with radioactive iodine ablation. And anyway, we know that it is a definitive treatment. If I'm even switching to propylthiouracil, there is no assurance that I will be achieving the euthyroidism and I may be able to withdraw the drug. Many patients with these drugs often fail and then they have to switch to the definitive treatment. So it's better now to consider radioactive iodine ablation. Okay. Next, which of the following is the earliest marker of megakaryocytic lineage? Okay, now I think we are switching into the pathology. These are relatively straightforward questions from your path. The marker is going to be CD41. Okay, so for your quick reference, I'm leaving behind a table in the notes PDF which shortlists all the CD markers and relatively important MCQ points that can be asked from that. So I think even the path Dr. Ranjit would cover all the CD markers. So this, take it as a kind of revision. Revise this before you give your path test. Okay, next one. A 6-year-old boy presents with pallor and jaundice. Peripheral smear shows small spherical red cells instead of biconcave RBCs. So I think the diagnosis is clear. They are asking what is the diagnostic test you would like to do. Pallor and jaundice. Why are we getting jaundice with anemia? Probably we are dealing with hemolytic anemia. Jaundice plus anemia should point towards hemolytic anemia. Any question which talks about jaundice plus anemia is talking about hemolytic anemia, with the added information that there is small spherical red cells. Yes, so this is all, with this information added, it is pointing towards hereditary spherocytosis, and you all know that for diagnosis of hereditary spherocytosis, the preferred investigation is going to be osmotic fragility test. There will be increased osmotic fragility, right? So why are we having the hemolysis here causing jaundice? Because these spherocyte cells, as they pass through spleen, they will be subjected to hemolysis. Next, a 25-year-old female presents with microcytic anemia. Her serum iron is low, total iron binding capacity is high, serum ferritin is low. What is the most likely diagnosis? So as you know, the iron picture is consistent with the diagnosis of iron deficiency anemia, right? So I think we don't have to have a major debate here. If it is anemia of chronic disease, mostly it is going to be presenting with normocytic, normochromic picture, at least for the exam. In real practice, almost all anemia of chronic disease present with microcytic hypochromic picture, because chronic disease are often accompanied by an added iron deficiency as well. Okay, the next question. A 30-year-old woman presents with easy bruising and petechia. Easy bruising and petechia. Her CBC shows platelet count of 20,000, normal PT and APTT. Her bone marrow shows increased megakaryocytes. What is the most likely diagnosis? So is this question talking about bleeding disorder or clotting disorder? So bleeding disorders primarily have defect in the platelet plug formation, and the clotting disorders have the problems in the coagulation cascade. So as we know, our process of stopping the blood loss from the injury to the blood vessels involves platelet plug formation and then fibrin formation. So let us say that at some point of time, somewhere in the blood vessel, there is an endothelial injury. And once there is endothelial injury, von Willebrand factors get exposed and activated. And those von Willebrand factors will now attract and attach the platelets. That will be my first step. We are going to call this as platelet adhesion. Once there is platelet adhesion, these platelets secrete more attractant chemicals to the platelets like thromboxane A2 and ADP. They will bring and more platelets get attached here. So now this stage we will call it as platelet aggregation. And once the aggregation is done, the platelet plug is formed. This will seal this site of endothelial injury and prevent the blood loss from continuing. But because these are not robust structures, I need to reinforce them by creating a mesh of fibrin. This fibrin mesh formation, we will call it as coagulation cascade. So this was my initial step. This step we will call it as platelet plug formation. After platelet plug formation, the second step is coagulation. In coagulation, primarily the fibrinogen that existed in inactive form is converted to fibrin, and I can reach this stage through intrinsic or extrinsic pathways, right? Activating multiple coagulation factors. Finally, I end up in a stage where I convert fibrinogen to fibrin and I deposit that fibrin. Now, this is a strong structure. This can hold the blood loss or prevent till endothelial injury is healed. Once the endothelial injury is healed, there is no longer need for the clot. I will dissolve this with TPA, because TPA will convert plasminogen to plasmin, and this plasmin will come and dissolve this clot, right? Plasmin is the fibrin breaking enzyme, and the clot is cleared, endothelium is healed, and the problem is solved. Now things can go wrong at the platelet plug formation level or in the coagulation cascade. So when things go wrong in the platelet plug formation stage, like for example, either platelets are low in number or they are not able to come and form the attachments, like one Willebrand factor is missing, such conditions. So in that case, we will have what we call as bleeding disorders. And if there is a problem in this coagulation cascade, we will have clotting disorders. The clotting disorders usually present with the few points that help you to differentiate between the bleeding disorders and clotting disorders. So in the bleeding disorders, you primarily have platelet defects, either qualitative or quantitative. Means either platelet quantity is less, or qualitative, like there is lack of one Willebrand factor, so platelet is not able to go and adhere, right, or other issues. In the clotting disorders, you have lack of coagulation factors, right? So you have clotting factor or coagulation factor defects. Okay, now in terms of features, these bleeding disorders usually, because first step is platelet plug formation. So if platelet plug formation is defective, as soon as there is injury, I will start bleeding, right? So there is immediate bleeding when there is trauma. You will not be able to stop the blood loss for a long time. On the other hand, in clotting disorders, platelet plug formation is fine. So when there is trauma, platelet plug forms. holds the blood loss immediately. But after that, I don't create the fibrin mesh. That is where I have the problem. So the blood loss is only stopped till the platelet plugs are fine. But if fibrin is not added, eventually platelet plug will be dislodged and I will continue to bleed. So they present with delayed bleeding. They present with delayed bleeding. Trauma now, hours later, patient will have bleeding. In case of platelet disorder trauma now, I will bleed now. Like I have a platelet defect, tooth extracted, it will not stop bleeding. I'll have continuous bleeding. If I have coagulation cascade disorders, I have a trauma. Then 3-4 hours later, 6 hours later, I notice that I have developed hematoma there. There is delayed bleeding. And then in case of bleeding disorders, we will have superficial bleeding. We will have superficial bleeding. But in clotting disorders, we will have deep-seated bleeding. Means mainly we bleed into joints. So when I say superficial bleeding, mostly we're bleeding from skin and mucous membranes, like oral cavity, mucous membrane and all. And in case of here, we are bleeding into joints and muscles and maybe even internal organs. So any question, if there is recurrent bleeding into joints and muscles, right, like hemophilia, clearly a case of clotting disorder. If there is petechiae, easy bruising, but no deep-seated bleeding, it's pointing towards bleeding disorders. So in this case, the question is clearly pointing towards bleeding disorder, right? So from this history itself, we can conclude that the problem is in the platelet. And when I look at the lab that the platelet count is low, it tells me that we're dealing with the platelet disorder itself. The platelet count in the periphery is low, but there is no problem in the bone marrow. Means megakaryocytes in the bone marrow are in fact increased. They are not decreased. So if they were decreased, I would have thought of some bone marrow pathologies. So what is the likely condition that we are getting here? So it means that the platelets are being destroyed or used up. That's why, despite having a normal bone marrow and normal platelet production by the bone marrow, I have low platelets in circulation, because either they are getting destroyed or they are being used up. So in DIC, they are being used up. In TTP HUS, they are being used up because these are all microangiopathies, right? Thrombotic microangiopathies. There is formation of multiple clots and platelets are being used up. In ITP, there is antiplatelet antibodies, which are destroying the platelets. That's why we are getting with the low values. Now, how will I differentiate between these? I have to remember one thing. In the conditions where there is thrombotic microangiopathy, there is also not just the platelet plug formation, there is fibrin formation. So I am consuming platelets and I am consuming fibrin. So when I consume fibrin, to form fibrin, I am consuming coagulation factors. So coagulation factors will be decreased. Right, then how will I get to know that, okay, there is lack of coagulation factors? I don't have to check for them. Please remember, in the bleeding disorders, there will be increased bleeding time, but normal clotting time. In the clotting disorders, we will have normal bleeding time, but increased clotting time. And whenever we have increased clotting time, that clearly points towards that there is a clotting disorder. To differentiate whether there is an intrinsic pathway defect or extrinsic, we do PT and APTT. And depending on whether I'm dealing with intrinsic or extrinsic, one of them or both of them may be elevated. If both of them are normal, that means I don't have intrinsic or extrinsic pathway defect. That means there is no clotting disorder. It's purely a bleeding disorder. But because these are both clotting and bleeding disorders, because I'm using both platelets and the coagulation factors, I'm expected to have abnormalities of PT, APTT in these conditions, but not in ITP. So here they have mentioned that PT and APTT are normal. So that rules out DIC, TTP and HUS, the classical consumptive coagulopathies. And we will stick to ITP as our answer, right? It is an immune disorder, immune thrombocytopenic purpura, where bone marrow produces normal platelets, but antibodies destroy those platelets in circulation, so platelet count decreases. And to respond to this low platelet count, bone marrow increases the platelet production. So megakaryocyte count increases. Clear? Okay, next, a 28-year-old female presents with menorrhagia and easy bruising. Platelet count is normal, but she has prolonged bleeding time. What is most appropriate initial test? Just give me a second. So what are we dealing here? Easy bruising, again pointing towards a bleeding disorder, right? Platelet defect. It could be quantitative or qualitative, as I told you. Quantitative means low platelet count, or platelet count can be normal, but other factors required for platelet function, like von Willebrand factor, these all may be affected. So from the story, can I think of bleeding time is increased? So everything is pointing towards a bleeding disorder, but platelet count is normal. So that means we're not dealing with a quantitative platelet defect, but rather a qualitative. So what is the most appropriate initial test to confirm the diagnosis? So among the qualitative defect, the von Willebrand disease is the most common, where there is von Willebrand factor deficit. So because of that, despite having normal number of platelets, the platelets are not able to go and bind to the site of injury to cause the initial adhesion. Yes, and when we have to diagnose the von Willebrand factor disease, von Willebrand factor antigen assay is considered as the initial screening test of choice, initial test of choice. So that makes the right answer, right? So just to summarize what we have discussed so far, platelet disorders can be qualitative or quantitative. Quantitative is where we have lack of platelets, right? And among them, we know that the most common cases of thrombocytopenia are all viral fevers, dengue, viral hemorrhagic fevers. Drugs like heparin, linezolid can cause, and then thrombotic microangiopathies that we discussed, DIC, HUS, TTP. In these cases, there is extensive clot formation in small blood vessels. For formation of clots, I'm using platelets, but also I'm using coagulation factors. So I will not have just the platelet defect, but I will also have abnormal clotting time. The coagulation cascade parameters will be abnormal. Then in terms of qualitative defects, I can have defects in platelet adhesion or defects in platelet aggregation. Aggregation is where after the initial adhesion, more platelets come and bind. Classical example for aggregation defect is Glanzmann's thrombasthenia. For adhesion defects, von Willebrand disease and Bernard-Soulier syndrome. Bernard-Soulier syndrome is quite rare. Von Willebrand disease is the most common qualitative platelet defect. Right. So in this question, we are suspecting that. So von Willebrand factor antigen assay becomes a investigation that can confirm the diagnosis here. Okay, next. Which of the following is the best choice for treating acute thrombotic thrombocytopenic purpura? So TTP is due to antibodies against ADAMTS13. Antibodies against ADAMTS13. HUS, is triggered by the dysentery, right? E. coli. Here, ADAMTS13, antibodies against it. So if I can get rid of these antibodies, I can treat the patient effectively, right? How can I get rid of the antibodies? Here, the platelet decrease in the platelet count is a secondary manifestation, because the platelets are being used in clot formation. The platelet count is low, right? If I prevent this clot formation, anyway platelets will not be used. So platelet transfusion is not something that I need to do. If I give steroids or rituximab, they may suppress the antibody production, but they will suppress antibody production. They will not clear the formed antibodies. These formed antibodies are currently causing the problem. The formed antibodies can be cleared from the circulation only by plasma exchange. So that makes our answer of choice, right? Plasma exchange can be considered. Okay, next, a 2-year-old child presents with pallor and hepatosplenomegaly. Hemoglobin electrophoresis shows elevated HbF and absent HbA. What is the most likely diagnosis? HbF is high, HbA is absent. Is it beta thalassemia, major sickle cell disease, hereditary spherocytosis, or iron deficiency anemia? What do you think is the likely diagnosis here? Okay, so thalassemias are those conditions where there is decreased hemoglobin production. There is decreased hemoglobin production. Why? Because there are defects in one of the hemoglobin chains, right? Alpha and beta thalassemias. If there is problem in alpha chain production, alpha thalassemias, beta chain production, beta thalassemias. So when we look at the beta thalassemias, you have the thalassemia trait where the HbA trait is where the defect is not severe. So you have more than 90% hemoglobin as HbA, right? But when you say thalassemia major, you have marked decrease or maybe absent HbA, and in that place you have hemoglobin F, which may range from 10 to 50% or maybe as high as 100%. So the HbA is going down in the beta thalassemia major, and that is being replaced by HbF. That's a basic understanding, right? So HbA may be totally absent and everything may be HbF. So in this question, that's what we find: elevated HbF and absent HbA. So this perfectly goes in favor of beta thalassemia major. Sickle cell disease, of course, we will have HbS. Iron deficiency anemia, we will not have this HbF elevation. Hereditary spherocytosis, we will not have that. So we will stick to option A as our answer. Next, a 35-year-old male presents with fatigue and pancytopenia. Bone marrow biopsy shows hypocellular marrow with fatty replacement. What is the treatment of choice? Okay, so whenever you have pancytopenia plus hypocellular marrow, pancytopenia, all the three cell lines or at least two cell lines are affected, plus hypocellular marrow. So what is it point? What are the possible differential diagnosis in this case? Now, if I have pancytopenia with hypercellular marrow or normocellular marrow, we would have thought of myelodysplastic syndrome or myeloproliferative diseases. When it is hypocellular, we have two conditions possible. What are those? One of them is aplastic anemia, the other one is myelofibrosis, right? So aplastic anemia and myelofibrosis. In myelofibrosis, there is fibrosis present. But if I have decrease in all the cell lines without fibrosis, instead of those lost cells, I have fatty degeneration or fatty changes. It is pointing towards aplastic anemia. So in this question, what they're mentioning is that hypocellular marrow with fatty replacement. This favors the diagnosis of aplastic anemia. Now, for patients with aplastic anemia, we can consider using erythropoietin to stimulate RBC production. We can consider using granulocyte colony stimulating factor to increase the neutrophil cell lines. We can also use thrombopoietin or L-thrombopags to stimulate the platelet production. But if you ask me, the effective treatments are the stem cell transplantation or anti-thymocyte globulin and cyclosporin. So we should, in this case, we should go ahead with anti-thymocyte globulin and cyclosporin as our answer. Next one, a 55-year-old male presents with generalized lymphadenopathy and hepatosplenomegaly. Peripheral smear shows smudge cells. What is the most likely diagnosis? So what do you think should be the answer in this question? What is the most likely diagnosis? Okay, so the next remaining questions are all hemat, and I want you to quickly give me the answers so that we can move forward to the next questions, because it's all paths. These are going to be image based questions and you guys are good in picking up image based questions. So smudge cells is primarily because of the destruction of fragile lymphocytes when we are making a smear, which is classically seen in chronic lymphocytic leukemia or CLL. The next one is a patient presents with prolonged APTT but normal PT. Which of the following clotting factor is most likely deficient? Patient presents with prolonged APTT but normal PT. Which of the following coagulation factor is most likely responsible. So as I've already told you, elevated APTT or PT points towards what? It points towards bleeding disorder, sorry, clotting disorder, right? Clotting disorders. There is a problem in the clotting pathway, either intrinsic or extrinsic pathway. So what helps you to identify whether it is intrinsic pathway defect or extrinsic? So please remember, extrinsic we have predominantly factor 7 involved, and abnormality to the extrinsic pathway leads to rise in prothrombin time. And intrinsic pathway, multiple factors are involved, and its abnormality can be detected by increase in APTT. So whenever APTT is increased, there is intrinsic pathway defect, and whenever there is PT increase, there is extrinsic pathway defect. And if both are increased, then there can be either defect in both pathways or defect in common pathway, right? So now in this question, what do we notice? We have prolonged APTT but normal PT. Normal PT rules out the defect in extrinsic pathway. Extrinsic pathway mainly involves factor 7. So factor 7 is something that I can comfortably rule out here. So I'm thinking of intrinsic pathway. So now what all comes under intrinsic pathway? What all comes under intrinsic pathway? I have factor 12, factor 11, factor 9, factor 8. So among the given option, factor 9 is mentioned. Factor 9 is part of the intrinsic pathway, right? So prolonged APTT is pointing towards defect in intrinsic pathway. PT is for the extrinsic pathway. So only factor 9 is from the intrinsic pathway here, and that is abnormal. So we'll go ahead with that as our answer. Okay, next is a straightforward question. A 6-year-old child developed jaundice and dark urine after taking sulfonamides. So you know from the history, this is talking about G6PD deficiency. G6PD deficiency. So that's a pretty simple and straightforward diagnosis. Next, a 45-year-old male presents with fatigue, weight loss, and early satiety. Examination, he has massive splenomegaly. CBC shows leukocytosis and increased myelocytes and basophils. Which of the following is most likely definitive diagnostic test? So story, what is it pointing towards? Increase myelocytes and basophils, right? Increase myelocytes and basophils. That means we are dealing with one of the myeloid neoplasms, right? Increased myelocytes and basophils. So we're talking about a myeloid neoplasm. Myeloid neoplasm. And if we are thinking about myeloid neoplasm, and if I have to consider CML, what will be the investigation of choice? Is it the bone marrow biopsy, peripheral smear, or BCR, ABL, PCR? The BCR, ABL, PCR is considered as the gold standard investigation. It is considered as the gold standard investigation. Of course, this story is not about the B12 deficiency. So this is not what I need to do. So we'll go ahead with BCR, ABL, PCR, right? So what is CML? In CML, the problem is BCR, like translocation T922, where there is fusion of BCR, ABL, and this fusion results in increased tyrosine kinase production, and this tyrosine kinase production facilitates the proliferation of myeloid cell lineage. And that's why when we think of treating the CML, we use tyrosine kinase inhibitors like imatinib, dasatinib, nilotinib, or bosutinib, which inhibit this tyrosine kinase, right? And if I can do a PCR to document the presence of this mutation, that's the gold standard. Okay, next. Pallor, jaundice, splenomegaly, peripheral smear shows target cells and Howell-Jolly bodies. That means there is increased destruction at the level of spleen. Hemoglobin electrophoresis reveals HbS 85%. What is the most likely complication in this patient if left untreated? So HbS means we are primarily talking about sickle cell anemia, right? we're talking about sickle cell anemia. Yes, sickle cell anemia patients are prone to develop the autosplenectomy or splenic rupture. They can develop aplastic crisis. They can develop gallstones because there is increased destruction of these RBCs, hemolysis. So there is increased bilirubin formation. They can precipitate and form gallstones. All these complications are known, but what they're asking is most likely. The most common complication that sickle cell anemia patients experience is vaso-occlusive crisis. Why? Because as the hemoglobin S level increases, the viscosity of the blood increases. Blood flow through organs becomes sluggish, and many organs experience ischemic symptoms. We will call them as vaso-occlusive crisis, which is the most common complication. Okay, next again, it's a very straightforward hematopath question. Clueless lymphocytosis on CBC and starry sky appearance. The moment we hear starry sky appearance, we know its question is talking about Burkitt's lymphoma, right? Rest of the things Dr. Ranjit will address in hematopathology. Okay, next, a 40-year-old male presents with fatigue, weight loss, and left upper quadrant discomfort. On examination, there is massive splenomegaly. CBC shows leukocytosis and increased myelocytes and basophils. Okay, the story seems familiar now. And cytogenetic abnormal analysis reveals a reciprocal translocation between chromosome 9 and 22. This finding is most characteristic of which of the following condition, right? So it's already the question that we have discussed. No need to elaborate further. Okay, so that was the last question, guys. So that completes our discussion for today. I'll be seeing you soon with some ABG based questions on the YouTube live. I will connect with you on that as soon as the questions are shared on the Telegram. See you. Have a good night. Bye-bye.